A very good morning to all of you. And it's my proud privilege as the ASI Jharkhand chapter chairman to welcome people of like thinking. And it was a vision long back with Dr. Sunil that we wanted to train all surgeons for endoscopy. Because obviously in my talk, I would be talking more about it, but we are really privileged to have all the distinguished faculty over here. And I would like Dr. Sunil to welcome the gathering officially.
Thank you, Arunima. I take this opportunity to welcome all of you, distinguished faculty, Professor B.K. Rao, our ASI National President, and also the Chief Trustee of IAGS, Dr. Abhay Dalvi, our IAGS President, Dr. Sunil Popat, and and many other distinguished faculty have joined, Dr. Satyapriya Desarkar, and all the distinguished faculty who are going to join. We have kept the topic. The vision, of course, goes back long, many decades ago, when I took up endoscopy, as many of you have taken up endoscopy. And the little effort which we thought we'll do is to at least try and train one surgeon from each district of Jharkhand at least, and adjoining border state. Let's see how much we succeed, but we'll need your support, collaboration, and blessings for that. Again, I formally welcome all of you for joining and gracing this occasion. Thank you.
We have the privilege of having the ASI president with us, Dr. Abhay Dalvi, and we have our distinguished chief guest, Professor Rao. So I would like Dr. Abhay Dalvi to kindly introduce the chief guest.
Good morning. Thank you, Arunima. Thank you, Sunil. It's a great privilege for me as ASI president speaking about Dr. Krishna Rao. What do I say about him? He has been my philosopher, guide in everything that I do. For IAGS, when I was president in 2015, and now as ASI president, I go to him each and every time. Dr. Krishna Rao has been the president of various societies, including IGS and ASI, and has done a lot of work for the benefit of all surgeons across not only the country, but worldwide. He has religiously followed the principles in which the surgeon comes up in life, even till date, and my salutes to him. As far as endoscopy is concerned, he undoubtedly, like Dr. Udwadia for laparoscopy, has been father figure for endoscopic services all across India. In fact, endoscopy was a surgeon's domain in the past, which gradually was handed over on a platter to medical gastroenterologists. He has been the father figure who has toiled hard to bring it back to a level back to the surgeons through his teachings as well as his involvement in various societies. And let me go on record that I learned upper GI endoscopy in '86, went on doing it till about 1992, having done a lot of therapeutic procedures, but had to give it up to medical gastroenterology, which I suffer even today. With these small words, sir, my pranam to you, and please keep going, and I will definitely do whatever in my capacity, whether I remain president or not, to uphold and propagate endoscopy to the masses in India. Thank you so much.
Thank you very much, sir, for introducing our chief guest. And I would like Professor Rao to first inaugurate this session formally by lighting the lamp. Sir, if you just give us a namaste, we would light the lamp on your behalf.
Please start the lighting of the lamp and starting of the program of endoscopy.
Thank you very much, sir. And I would like you to address the gathering and say a few words to encourage us.
Thank you, Abhay, for your nice comments about me. Our association has been there for more than 4 decades, and I appreciate your involvement in IAGS and ASI. Jharkhand President Dr. Verma, Sunil Kumar, President IAGS Sunil Papat, and others were on the program. I've been asked to say what has been my road to the present day of endoscopy. My interest in endoscopy started when I read an article in the magazine Science way back in 70s, which talked about fiber optic endoscopes and a short colonoscope by Horswich and Dr. Singh. And that put me to an inquiry mind to learn as to where I can learn about it and get trained. Only place I could find was with Professor Morrissey in University of Wisconsin, United States. He unfortunately told me that he does not take overseas doctors and that he is booked for 2 years. But my colleagues who are in the States, particularly in the Loyola University, wanted me to come over and be observer and learn on my observation the endoscopic procedures. On landing in States, I contacted Professor Morrissey, who remembered my letter and told me that a fortnight hence, the candidate was supposed to come for 2 weeks of training. I had met with an accident and that fortnight is vacant for me to take it up. That was the beginning that I took over. And during that period of training, not only did I have direct handling of the fiber optic endoscope, the teaching attachment. That went on from the morning to the lunchtime, and whole of the afternoon, we had about 100 Kodak carousel slides, which we go through with explanations as to what the slide shows, what the pathology is, what the endoscopic picture is, and how we avoid complications and maintain the equipment. That was a good beginning, and thereafter I came down to London to North Whittington Hospital. I spent 6 weeks in learning the process. After coming back, I was able to get the upper GI endoscopy. Finance was a problem because it was a personal investment. And after a period of nearly 18 months, I decided to go to Japan for further training and also for colonoscopy. It is a difficult time to be in Japan at that time because hardly anybody speaks English, and being a vegetarian, it was very difficult to survive. After 6 weeks, I found that the approach of the Japanese and the Western world were completely different. I used to give intravenous sedation, almost knocking the patient out before doing an endoscopy. Whereas the Japanese, the patient came, moved to the doctor, sat in a chair, opened his mouth, the scope was passed down, and the upper GI was inspected, recorded, and diagnosed. The same thing I started following when I came back, and after that, I had the opportunity to visit NIBS Ohendra and Peter Cotton for the ERCP training. At that period of time, I had no one in India to fall back on to get some help, some assistance in India. And I had to be in touch with my friends in Japan, NIBS Ohendra and Peter Cotton. At that time, there was no internet or WhatsApp. So by the time we wrote a letter and got a response back, it would be more than 2 to 3 weeks. The only time we were in contact were at the endoscopy conferences, where I used to compare my difficulties and get some clarification from them. Most of you know that NIBS Ohendra has been involved in a number of cost-saving methodology. We used to make biliary stents from rolls of 8 mm, 8 French and 10 French polythene tubes. And he taught us how to do stents which cost us less than 5 rupees at that time. And the Olympus and other stents were exorbitantly expensive. He also showed us how to prepare a needle knife, the sclerotherapy needle, a sphincter toe. He also came up with a new idea of injecting the malignant obstructive carcinoma of the esophagus with adrenaline, which causes tissue necrosis and relieve the dysphagia. His hemostatic methodology was very clear, and I learned a lot from him when I spent the time with him. Coming back to India, I was supported by only very few people, one of them being my professor of surgery, Dr. Chalichandra, who made a comment, Krishna, I can see the ampulla much better through the endoscope than when I open the abdomen and do a duodenectomy. He also was supportive of various procedures that I used to do. Of course, the detractors, my own colleagues said that I was passing a rice tube, and one of the physicians showed a stomach washing tube with a funnel at the top and said that I was passing this sort of instrument in doing endoscopy. Fortunately for me, my work and my presentations converted all those negative aspects of the physicians and surgeons. And when one of the surgeons, who himself criticized me for saying, Krishnarao, you are a Johnson medalist and you are passing a rice tube, he came around and said, Krishnarao, I want you to do this thing for me. I have a polyp in the colon, I want you to remove it. So that was the turning point, and my lectures in the various meetings of ASI, state chapters, regional meetings, city chapters, and I was helped by the Olympus representatives to carry the instruments from all over India to do live demonstrations of what is possible. One that I cannot forget is the one organized in Tuticorin by Dr. Arul Raj. I landed there early morning at 6:30. At 7, I was at the Kalyan Mandap. There were more than 1,500 IMA delegates. There were multiple televisions put up on the thing, and on the Kalyan Mandap, there was a table provision to do upper GI endoscopy. That seems to have converted a lot of people of the necessity and importance of the endoscopy, both upper GI and lower GI. Over the period of time, I improved myself trying to do therapeutic procedures, and I was the first one to do a biliary stenting in India and reported in the Indian Society of Gastroenterology. The surgeons came to me not only because of the open surgery that I was doing, liver resections, pancreatic duodenectomy, and cancer surgeries. They also wanted to see what does this endoscopy can do for them. When they came and saw the procedures that was being done, that 85% of the benign lesions of the upper GI pathology can be dealt with endoscopically without the need for surgery. The one person who saw the CBD stone being extracted by ERCP, sphincterotomy, and basketing told me, Sir, why did I become a surgeon? That was a bit too late. He was nearly 50 at that time. Again, these procedures and demonstrations had induced a number of surgeons to take up endoscopy. As you know, each person has got their own limit of performance of surgery, endoscopy, or laparoscopic procedure. So step by step, they used to go up. What I had to go to abroad to learn, today I am so happy to see there are a number of surgeons doing not only diagnostic, but therapeutic endoscopy, teaching them to the juniors, which was never heard of in the past, because they were considered that they will become competitors for them in their private practice. Today, there are innumerable centers doing excellent endoscopic procedures and teaching the youngsters the other modality of management of surgery by endoscopy rather than by open surgery. Of course, in between comes laparoscopy, and so we have got the three arms for the surgeon: open surgery, laparoscopic surgery, and endoscopic procedures to determine which is the best mode of management, singly or in combination for a patient with a pathology. When I look back at the development of the endoscopy, the one point was the introduction of video endoscopy. This resulted in the teaching capacity of the endoscopist to his assistant, and also to transfer this to other centers for teaching purposes, and in return, if there are any doubts, get it clarified. This was introduced in the 1986 ISG meeting in Chennai, and thereafter there has been a tremendous increase in the interest in endoscopy and therapeutic endoscopy procedures. Friends, the budding surgeons today have to know what is good for the patient. I always say, I know this procedure, and so that is the best procedure for what disease that you have. But I should like to know, there are these three options or four options: open surgery, laparoscopy, endoscopy, combination of this. Which of this is good for you? Which is recommended to you? And hence, the present day surgeon should be well versed with what is recognized, accepted mode of management of various diseases. I am sure that the galaxy of stalwarts who are going to talk to you today, and thereafter in the IAGS we have various YouTube lectures on therapeutic procedures. I am very glad to note that yesterday there was a tweet that the ERCP lecture and demonstration by the IAGS Honorary Secretary Ishwar Murthy had 12,000 viewers. So not only do you hear the experts talk today, you can go back to YouTube, but see the various procedures that can be done, learn from them, go to centers, get personally trained, come back and do the procedures at your center. Sunil, I congratulate you and the Jharkhand chapter for organizing this endoscopic seminar for practical purposes, and I'm sure it will also have a number of videos to explain the various therapeutic procedures that are to be done. Again, I would like to say that as in surgery, as we start with hydrocele hernia and piles and go up to hepatic and magnetonephrectomy, we also have to progress from routine diagnostic procedure to complicated, highly sophisticated endoscopic treatment for the patient. Thank you, Sunil.
Thank you very much, sir, for giving us a brief of your journey, which is really inspiring. And I'm sure many of the surgeons will take a lot of message from there. And also thank you for showing us the direction ahead. I think with this we come to the end of the inauguration, and we would directly go ahead with the scientific activities. And I would like all of you to stay on because it would be very encouraging. So first of all, I would like to welcome the chairpersons for this session. That is Dr. Achal Gupta, who is the head of the Department of Surgery of GR Medical College. And we are privileged to have him with us. And with him, we have Dr. KK Singh, who is also Professor of Surgery in Jharkhand. And I would request them to welcome our speaker, Dr. Sunil Kumar.
Good morning, everybody. Hello, can you hear me?
Morning.
Yes, yes. Please go ahead.
Welcome, Dr. Sunil. And Dr. Sunil does not need any introduction. He's just like an elder brother to me and very vibrant. And he not only believes in doing surgery, he also believes in teaching the younger generation. And so this is this conference. And today, mainly we'll be speaking on endoscopy and the use of endoscopy to the surgeon, from the surgeon point of view. So, Dr. Sunil, please, all yours.
Thank you, Dr. KK Singh and Dr. Achal Gupta. Both of you are my dear friends. I'm going to talk on a subject which appears little dry because even if all of us are doing endoscopy, some of us may not be interested or inclined to know about how the endoscope, what we do today, has evolved over centuries, and we don't know the anatomy of endoscope, what lies inside, how the image is captured. We do many higher things like doing endoscopy, recognizing pathology. So in next 15 to 20 minutes or so, I will be giving you a kind of helicopter view about evolution of endoscope and anatomy of endoscope. In evolution of endoscopy, I will be touching on these headlines. How come the concept of endoscopy, era of rigid endoscopy, era of semi-flexible endoscopy, era of fiber optic endoscopy, era of video endoscopy, that is what we are doing today, and what are the recent advances in endoscopy and what lies in the future of endoscopy. While discussing concept of endoscopy, it was Philip Bozzini in 1806, an Italian-born German who designed a light conductor known as Licklighter, made of candlelight source reflecting mirror and speculum. Then Antonin Desmarquis in 1853 designed a scope lit by turpentine oil, and he is believed to have coined the term endoscope. Maximilian Nitze in 1848 to 1906 designed a cystoscope using electric bulb. All this talk is based on a very nice book written by my dear friend Iswar Murthy. And for any beginners or people who are starting endoscope, that's the big book to keep. I always keep that, he gifted to me. Then era of rigid endoscopy, it was Adolphe Kusumol in 1868, designed and initially performed rigid endoscopy. Jan Mikulis Radecki, who was a Polish physician, considered as father of rigid gastroscopy, he did work on design of endoscope and insufflation and removal of secretion. It was Chevalier Jackson in 1865 to 1958 at Pittsburgh in USA developed a rigid esophagoscope. Then era of semi-flexible endoscopy, it was Rudolf Schindler who designed his novel semi-flexible endoscopy with the help of company Wolf. It was a tube of 75 centimeter length and 11 millimeter diameter, and about 1/3 of the entire length of the tube toward the tip could bend to a certain degree. Eyeless gastro camera in 1950, few doctors in Tokyo requested a company to develop a camera that could photograph and examine the interior of stomach. So it's very fascinating how the whole endoscope which we do has developed over century. Then came the era of fiber optic endoscopy. It was Harold Hopkins and Narendra Singh Kapani, they are credited with the design and development of fiber optic cable, which was composed of 1,000 tiny glass fibers. It helps to transmit light and image from one end to the fiber to the other end, even when it is bent, and due to the mechanism or process of total internal reflection. Basil Hirsuk is in 1960 considered as father of fiber optic endoscopy and credited both for designing it and for its clinical application. Then came the era of video endoscopy, the era in which we are at the moment. And the few important things in video endoscopy is the knowing about CCD chip, video processing unit, light source, which can be either halogen or still better xenon. The advantage of video endoscopy that image quality is better, the teamwork is facilitated, and therapeutic endoscopy has become a very simplified task. Transmission of image to the monitor and then to the storage device and then to the next room or even to the next continent is possible. And what has video endoscope given to us? The training has vastly improved and documentation is much better. As Professor B.K. Rao was alluding to, that in that time and even our initial time, we used to use fiber optic endoscope and by a teaching scope, we used to call it lecturoscope, we used to see it. But with video endoscopy, training has become vastly improved. So high definition system has come, which is also being used today for a higher resolution of images and videos. We have image contrast technique. They let us see the submucosal changes like any flat polyps and early cancer by spraying the dyes, that is chromoendoscopy, or using special filters, which is narrowband imaging. We have magnification endoscopy, zoom endoscopy for tiny inconspicuous lesion in gut. Then you have a capsule endoscopy, which is a swallowable wireless miniature camera. The future of endoscopy lies in the teleendoscopy, robotic endoscopy, and endomicroscopy. Endomicroscopy basically is a optical biopsy. It gives you a real-time histology-like picture of internal lining of any organ. The next part of my talk will be knowing your endoscope. That is the anatomy of endoscope, which many of us may not know. We just do it. We can pick up lesion. We can treat lesion. It's very important if you want to be proficient is to know your craft. It consists of 3 heads: control head, that's number 1. You have an insertion section and umbilical cord. Control head is the heart of endoscope. It has all the wheels, locks, and buttons, as you can see in the picture. Very important to be conversant what each structure does. So big wheel for moving the scope tip up and down. Small wheel for moving the scope right and left. Each wheel is guarded by a locking latch, which is a safety device. And pushing the locking latch forward would unlock the scope. Then we have 2 big detachable and color-coded buttons in front of the control head. Superior button, which is red-coded, is for suction. S for superior, S for suction. And we have inferior button, which is blue color-coded for insufflation of air and instillation of water. I for inferior, I for insufflation and instillation. Continuing with the control head is connected to the light source and video processing unit through the umbilical cord. We have biopsy channel at the junction of place where head is attached to the insertion section. You can see the insertion section, which is flexible insertion section of various lengths and diameter. Adult endogastroscope is usually 110 centimeter long and about 9.2 millimeter of diameter. We have pediatric endoscope available of a different length and different diameter. The distal most 15 centimeter is the bending section, and important structure which lies at the tip is the lens and the various channels. This is umbilical cord, which connects the baby, which is the endoscope, to the mother, which is the processing unit. It carries the image guide cables, light guide bundles, suction channels, and water and air feeding channel between scope and processing unit. The supply plug connects the umbilical cord to the processing unit. We have light guide bundle image guide bundle, suction and instrument channel, water jet, air feeding channel, pull wires for bending section inside the insertion section. The two important things which lies at the inside of endoscope tip is the lens, objective lens, and the CCD chip. Pulleys attaching the pull wires to the big and small wheels, and all cables and channels extending to the umbilical cord. These are the things which lies inside the control head. So last couple of slides, this is I am only giving the mechanism of the video endoscope because we no longer use the fiber optic endoscope. You can see the yellow coded light in the picture, which is the light guide bundle. You can see the blue lines, which is a image guide cables. Tip of the endoscope, you can see objective lens, and behind that is the CCD. And you can see the yellow light guide bundles going to the light source. That light comes from the light source, goes through that. And then blue image goes to the video processor, and video processor goes to the TV monitor, which is the final captured image. It is important to know how all this image is captured. So as I discussed the light, we have light conduct bundles and image guide cables. So what happens actually, the light from the xenon or halogen light source is carried by the light conduct bundle, which is yellow coded for clarity of understanding. So light conduct bundles to the endoscope tip. So light comes there in the endoscope tip. An objective lens at the endoscope tip focuses that image to the CCD chip. And the function of CCD chip is to send the electrical signal through the image guide cables, which you can see as a blue line, to the video processor. And video processor, by the various computerized mechanism, processes those images and makes it optimal. And it is then displayed at the TV monitor for us to see the pathology. A word about CCD chip. It is charged coupled device in endoscope. It's a solid microchip used for image sensing. A pixel, we talk about pixel quite a bit in the endoscopy, which is basically a picture element which represents the limit of image resolution and is the basic building block used to recreate an electronic image. More the number of pixels, better the resolution of image. As in a standard endoscope, which used, it's approximately 1 to 4 lakhs pixel. And this standard endoscope magnifies the endoscopic image 30 to 35 times. So whatever we see in the TV monitor is the 30 to 35 times magnified view of the actual image. But in a high definition, which is much better and used now these days, we have approximately 1 million pixel, and it gives quite a better resolution and image clarity so that even the minor pathology can be picked up. So with this talk, I just want to give 2 take-home messages. It's very, very important, pertinent to know the anatomy and physiology of your scope for a better upkeep, better maintenance, durability of the scope. And desirable to know the evolution of scope, how our scientists have contributed over centuries to develop this tool for service of mankind. It is just about being grateful. And with this, I come to my end of my talk, and I thank you very much for a patient hearing. Thank you.
Thank you.
Thank you, Sunil, for a lucid talk on evolution and anatomy of scopes. I think the future is still not ready for things. The way the scopes are developing now, I think everything will be seen and done through these scopes in the future. Even the laparoscopy may go away. I don't know. So thank you very much for the kind talk. Yeah.
Thank you, Dr. Sunil.
Okay, thanks.
Thank you, Dr. Sunil, sir. So to move on to our next topic, which is steps of upper GIscopy for beginners by Dr. Ishwaran Murthy, and our respected chairpersons will be Dr. Nalini Kant Chaudhary and Dr. Achal Gupta, sir. Dr. Ishwaran Murthy is MS, FRCS, FRCS Edinburgh, FRCS Glasgow, FAGS, FMAS, FIGS, FALS. He's a chairman at Tamil Nadu and Pondicherry state chapter of ASI, and sir has been an excellent teacher for upper GI endoscopy, colonoscopy, ERCP, and sir is very famous among young surgeons for his quiz contests. And I am very happy that I was one of the winner of the quiz contest done by Ishwaran Murthy sir. So I would like to invite Ishwaran Murthy sir for his illustrative talk.
Yeah, Dr. Ishwar Murthy is also the secretary of IAGS, very passionate teacher.
Dear friends,
and
ladies and gentlemen,
of mine.
welcome to
And
Mission
we'll be speaking
Endoscopy
on
Training
steps
for
of
Surgeons.
UGIscopy for beginners. Ishwar,
Friends,
over to you, please.
Flexible endoscopy training is essential for every surgeon in this era of minimal access surgery. You all know that. Here today, like the first class in your driving lesson, we are going to tell you the very basics for you to navigate through the upper GI tree using a gastroscopy by showing the basics what postgraduates or trainees should understand, and also by means of 2 virtual live cases I am going to describe all the key steps of upper GI endoscopy. As you can see here, every time when a pilot starts a plane, he does what we call a cockpit drill. Like that, before you do or embark on any endoscopic procedure, please go ahead with 2 important rituals. The ritual number 1 is endoscopy checklist. See the scope is in good condition, it is working, the suction, irrigation, everything is as per this list I have given it here, and then you proceed. The next important thing, of course, is a patient checklist, because though you are doing a procedure like a technician, but you have to remember we are all clinicians. So, we should know why we are doing the procedure, the indication. Like if it is a case of a GI bleed, we know what are the pathology we might see. If it is a dysphagia, what could be the cause for the dysphagia in this case? Like that, we should have a background clinical diagnosis before we embark on the endoscopy. Second important thing, I would say more important, is to verify there is no contraindication for doing the procedure, because if it is a case of a severe epigastric pain in an elderly man, it could be even a ischemic heart disease, an inferior wall MI. So, if you suspect, better you do like an ECG and TROP-T and get a cardiologist before rushing him for an endoscopy where things can go wrong. So, you have to be very careful where not to embark for an urgent endoscopy. It should not be an act of desperation. The third important thing I would say is a drug history. Like for example, in a patient with diabetes, COPD, ischemic heart disease, you have to evaluate the patient and put them in the ASA grade 1, 2, 3, 4, 5. If anybody beyond 3, you have to be very careful, think twice before doing endoscopy. Even then, preferable to have an anesthetist with you. And also, if they have a drugs like clopidogrel, aspirin, you may have to stop 5 days before doing the procedure, because any biopsy may endanger excessive bleeding. The fourth important thing, all of you, I need not tell you, importance of informed consent, as you can see in here, in the patient's mother tongue. Explain why we do, how we do, what are the benefits and risks and alternatives, explain them by giving them an information leaflet, then you try to perform. The last 2 things are very important. Always educate your staff that they verify the patient has been fasting for at least 6 hours or more and they do not have any loose tooth or dentures. So, be a good clinician before you do an endoscopic procedure. There are some language I wanted to share with you what we usually treat. See, for example, you see a big screen here. So, you treat every screen you are going to see like a monitor, like where is 3 o'clock, 6 o'clock, like that. Because if you treat the monitor like a clock, and then whenever I describe a lesion, you will be able to understand. For example, if you see an access channel where the biopsy forceps, all the accessories come out, in a Olympuscope, especially in upper GI endoscopy, it will be around 7 o'clock position, as you can see here. For example, if it is in the pendex, it will be somewhere at 5 o'clock position. So, you should know where the access channel and how it looks like in the monitor. That is an important thing. The second important thing is you have to have a good control. For example, if I am using a right hand individual, I will take the scope in my left hand and non-dominant hand, I will take a full control of my control head like this. Then as you can see, I allot these two fingers for the buttons and I embrace the scope like this. And my thumb is a key thing which will rotate the big wheel towards me. As I rotate the scope, the big wheel towards me, I start looking upwards like 12 o'clock. For example, if the small wheel, if I turn to away from me, I start seeing the right side. So, turning to the right is small wheel away and always looking up, that is big wheel towards. These are the two key movements you should really understand. So, all these things I am sure you will see in the live scope. And the next important thing is you should be, I am sure all of you are already a laparoscopic surgeon, you know what I mean by ambidextrity. You have to have a full control of your scope, like here for example we are demonstrating, you have the control head in your non-dominant hand and also your hand, the right hand is holding the shaft like what I am doing. So, if you just turn the shaft clockwise, you turn to the right. If you turn it to the anti-clockwise, you turn to the left. So, this turning of this is done by not by the small wheel any longer, it is mainly by the soft movement. That is why, and more important thing, especially when you go into the D1 to D2, you know how important to have a body movement. So, the wheel movement and the shaft movement and your body movement. For example, if I want to just to turn to the right like this, then from D1 and to D2, I have to turn myself from looking at the patient to looking at the monitor here if it is present. So, this corkscrew movement is going to keep me stationary in D2. So, all these things are important and also important as you can see in this picture. Try to picturize this stage here. All my staffs are here for example, and see where I am standing with the patient in the left lateral position and see the number 1, 2, 3, 4, everybody has a role to play. For example, here this is the key staff nurse as you can see, number 1, she is going to hold the patient's mouth guard, reassure the patient as the procedure is done. This lady restraining nurse, she is going to administer drugs if necessary and also keep the patient comfortable, and the one behind me here is the very important assisting nurse, she will help me with all the accessories, and one here hiding here, she will do all the recording. So, all are important and see how it is going to be held in a left lateral position. Very important thing is she is holding the mouth guard and also with the other hand she is just supporting the occiput. So, the patient is not unnecessarily extending. Do not keep it a big pillow, and also a pillow may not be necessary in a child, but in an adult you should have a small pillow like this, and the mouth guard is not only patient is teeth is protected, your expensive the last 15 centimeter of endoscopy is also protected. The next important thing I would say is the safety of the patient while you are doing. So, always as I said the importance of checklist, then always be vigilant. Always, even though I am looking at the monitor, always keep an eye on the patient and I will teach my staffs. And we have a habit of always giving a nasal oxygen to the patient, and also you need to have a pulse oximeter, ideally an ECG lead in a ischemic heart disease patient. Keep the suction ready, 2 suctions, one for the endoscopy, one for the oral suction for this patient, so that patient is not full of froth. And if there is a patient with a high risk patient or a patient with a foreign body or a child, then you may have to have an anesthetist standby. Always you should have the resuscitation team and ready for action. So, these are all the requirements for an ideal endoscopic procedure. Let me now take you to 2 procedures where I am going to tell you all the key steps to navigate esophagus, stomach onto the D1 and D2, come back, not to miss any lesions and safely perform a procedure. Let us go to the first case now.
So, this is 45-year-old male patient. Actually, he came for the diagnostic endoscopic procedure. The indication is dyspepsia and ascites. The comorbidity is chronic liver disease with the patient is a chronic alcoholic patient. He is currently on beta blockers and proton pump inhibitors and diuretics. He is having no allergy and no surgeries.
We are going to do the diagnostic endoscopy. If you have a panoramic view of the endoscopy room, endoscopy is essentially a teamwork. And there are three important people here, I would say, in addition to me. Of course, one, to keep the patient comfortable, airway under control, you need to have somebody vigilant. If it is done in the outpatient setup, you have a staff nurse who will monitor. We have the luxury, and also we have our anesthetist here, Dr. Thirumalai Raja is here. He is going to give conscious sedation. Next, of course, is the head end. We have a staff to control the mouth guard, and I have an assisting staff nurse, Suryakala. So all three of us are there, and I have a monitor here. And accordingly, because they are all coming in what we call the tower principle in our country, but ideally you need to adapt what we normally do, our endoscopy or laparoscopy, straight line principle. I am standing, as you can see, the head, I'm just having about 15 degrees away from the patient's head, about 2 feet away from him, comfortably holding the endoscopy, which is an Olympus GIF H170 series, because it has the image enhancement and magnification also. It's a very good endoscopy. So I'll hold the control head with the non-dominant hand, engage my 2 fingers to the button, and allot my thumb to control the wheel. The most important wheel for the beginner is to the big wheel. All the movements you can accomplish by simple single movement, that is big wheel towards you. That's all. If you don't want that amount, you can always make it away from you. It will correct itself. Otherwise, most of the turnings and movements are done with a big wheel towards me. That's the one thing you understand. The second important thing is soft clockwise rotation. And sometimes when we go into the duodenum, we'll tell later my little bit of body movement. So wheel, soft and body is going to tell me where I am navigating. So let us go, quickly go, have an idea overall, then we'll put it in small pieces for you to understand better. So the patient is anesthetized. I am putting it inside. As you can see, the first important thing is you look the monitor as a clock. So the 6 o'clock is what is seeing is a soft palate. 12 o'clock is the upside down view of the tongue. You will be able to see that. And you will see the uvula, you may not appreciate, but what you can appreciate further is you can see the epiglottis, a glimpse of epiglottis. What is in front of the epiglottis is vallicula. You are not interested, you have a glimpse of the vocal cords arytenoid fold. That also you can very easily say, if you are treating like a clock, what is towards the 3 o'clock position in your monitor is the right vocal cord, right arytenoid fold, right piriform fossa. This is the right piriform fossa. This is left piriform fossa. So you go to the left piriform fossa and then just gently negotiate, and with the insufflation, this is what we call a direct intubation, and you will be able to enter the esophagus. The art of examining all depends upon how you control both the wheel and also the 2 buttons. So the superior button is suction. We don't use it that often unless there is some bleeding and fluid. The inferior button, if you place the hand like this, give your middle finger there and give your index finger for a superior. Okay, I'll just put a hand always. You see, my suction is not necessary, only the insufflation. So you can't. So inferior button is important. I go, and you can see the importance of torquing. You can always have a look here as we go. He is having in the esophagus momentarily small dilated veins which are grade 1 varices. As I said, our aim today is to teach you navigation, but there are pathologies here. This is called, there are at least 4 columns of dilated veins. They are between grade 1 to 2. Then say this is close to grade 2 or even 3 some people. And also there are some other telltale evidence to say they need further treatment. Okay. Then you enter the stomach. The stomach also, if you see here, there is a lot to learn. So you have a typical condition, this one. This is called congestive gastropathy. Okay, you can see it's like a skin of a crocodile or a snake. So that is another thing you are able to appreciate. But what we are interested is to, as soon as you go in, distant, the rugal folds disappear. You go, turn the scope, clockwise torque, big wheel towards me. You just keep pushing. Then you will see the pylorus. Your aim is to bring the pylorus bang right on the center of the screen. So your scope, when it is straight, it is at the center, you will be able to enter and you will be knocking the door of a D1. This is actually D1. What you see in front and more towards the 9 o'clock is actually the anterior wall. What you don't see, which you want to see as a surgeon, is a posterior wall. For that, the body movement is very important. I turn my body like, see, for example here, and also small wheel away from me. I will be able to see not only the posterior wall, but also I may be able to progress further into the D2. So that's another important thing you'll see. So what was featureless now becoming a horizontal valvulae conjunctivis with again the clock position. If you carefully watch bile and also the ampulla, the only vertical fold on the medial wall, that is at 9 o'clock, is ampulla. Being an end viewing scope, you are not able to appreciate it as good as in a side viewing scope, but this is all. The end point of the endoscopy is growing, reaching up to the ampulla, say hello to it. And as you do, then you come back. I'm doing something which I'll tell in the next module is shortening the scope. Then I'll fall back in the stomach antrum. Then I'll again the big wheel slightly to the towards me. So I'll see a ridge-like structure stretching from around 8 o'clock to around 2 o'clock position. That is you call the incisor along the lesser curve. Then if I do full J maneuver or fully flux this and take the anti-clockwise and pull the scope, I look at, you can see the congestive gastropathy is very much, and because he was retching a little bit, so there is a venous oozing. This repeated oozing is the cause for chronic anemia. So that is one thing. So we can reduce his portal pressure by giving him some beta blocker, but he has no fundal varices. That is the most important thing you have to understand. Then you again correct yourself. And the last thing is what we do is a distensibility test. I'll just suck all the air I insufflated and see the suction, all these rugal folds and veins. See it is collapsing right in front of you. Suck all the fluid and start coming. As you come also, like in colonoscopy, withdrawal also sometimes show you all the lesions. Don't be in a hurry to take the scope, but always take time, especially the fluid in the fundus. But in a patient with the varices, you should be careful not to suck on the varices, because then what was a sleeping tiger will wake up and it will start becoming ferocious, and bleeding at this time is unwarranted. Okay, so I'm just keep coming, and you look at my right hand, I'm actually kissing the patient's mouth, because when you have the hand right on the patient's mouth guard, your control on the shaft is so good, you can take it a millimeter at a time, so that otherwise what will happen, patient if is retching, he'll vomit. And also you have to instruct your staff nurse, in case you are taking the hand from here to the shaft, she will hold. So she will do what you are doing. So I'm just coming at the, and you can always teach the staff what is the level you are in. Now for example, you are exactly bang at 15, so we are right at the cricopharynx. Big wheel towards me again. Whenever you have to see something, big wheel towards you. Remember that is well enough for this first module. Then you will be able to see the vocal cords again, and you have a glimpse. Don't leave it for the ENT people to diagnose the piriform fossa growth and vallicular growth, thing like that. Then you aspirate, and uvula is seen like a polyp. Don't remove it. It is just uvula at 6 o'clock position. And you haven't seen the teeth. That is the way you should do. Keep it at center. Don't see the dental examination come out. That's all over. Thank you.
Patient is currently on proton pump inhibitors and antacids, no allergy, no previous surgeries. The previous endoscopy showed a duodenal obstruction, which was done 3 months back. Since this is a COVID era, we have done a COVID test for all the patients, and it is negative for all the patients.
Okay.
Over to Dr. Iswarabutti, sir.
You see my stance again. Stand at ease. Hold it comfortably. Make a gentle curve with a big wheel towards you like this. So we are ready to go. So these are the 3 things. And we already know what is doing. Each finger are allocated to control the buttons and wheels, which we already know from our first module. Now I am going to place it just over. The first is a surprise finding of having the upside down view of the thing, because that is because of the configuration. Okay. So as you go in, I'll go into the postcricoid region. As I said, I'll be going, this is an anxious patient, and I'll be the shortest time where I wanted to spend, so I'm not going to dwell into what we have already done before. Here what I'm going to do is, as soon as you reach the OG junction, for example, this is the gastroesophageal junction, okay? There you just, if you have the luxury of narrowband imaging, this is esophagus in MBI, and the transition you will be able to appreciate very well here at the bottom, at least at 6 o'clock. So squamous column, any Barrett's extension you will be able to appreciate. So that's the additional advantage of having a high-end, high-definition endoscopy. Then I'll just go to the white light, because that is what we wanted to do. As you go inside, if you walk towards 3 o'clock, you go dive into the the body onto the antrum. As you can see down further in the darkness, you see the antrum taking a right turn, okay, towards 3 o'clock. So what you should not do is, you should not go towards the 9 o'clock. If you go 9 o'clock, then you will be entering and spending all the time. Getting lost in the roomy stomach is a problem for the beginner. How to avoid that? You have 3 things I am going to tell you, repeat for your life. What are the 3 things? As soon as you go, if there are any fluid, you suck, of course. Distend the stomach enough to have a comfortable patient. Then push the scope, number 1. Turn the scope clockwise, number 2. And big wheel slightly towards you. And if you have a beautiful view of the stomach, what you see on the floor, that is 6 o'clock, is the greater curvature. What you see on the roof is the lesser curvature. What you see at 9 o'clock there is the anterior wall. Can you press on the anterior wall? Okay, you press pannunga. My anesthetic is pressing, press, relax, press. See, that is the anterior wall. Posterior wall, if you have a pancreatic cyst or something, that will be coming. So you know orientation, walk along the greater curve. Then what you do as you go further and further, I'm doing a little torquing to the right and also big wheel towards me. So when I turn the big wheel towards, I push, the pylorus is coming towards me, and try to put it at the center, and I am taking all my things in the wheel so that it is straight. The scope is looking straight like this. So end facing pylorus right at the center, very center, then you will be able to enter. You can see here there is some small changes here and the scarring and also duodenal erosions. Then I turn the small wheel away and then big wheel like this, then I go further in. There was no obstruction now, as you can see, is all healed. There is a minimal scarring only, you can appreciate. I can go right into the second part. And what I have done just now is shortening the scope. Then after that, I am just going to hold the scope very close. As I said, whenever I want to have a better control, see, this is actually right to the ampulla. You can see the ampulla vata slightly. You have a glimpse of that at 9 o'clock position. And then slowly come back the shortest route. And you can see the villi, how easily the villi is seen. Also in one case, by just underwater examination, the importance of seeing and also taking a biopsy, especially if you see a case of chronic diarrhea. Okay, now you fall back. So what do you see here is actually deformed. You can see the duodenum is deformed. That's all I can tell you. But it is not anymore stenosed. And it taking an acute right turn like this. But there was nothing like, this is the exact place where she had a stenosis. Now it is easy to go in. Your scope diameter is 9.2. I'm sure it is 10 to 12 millimeter diameter is good enough for her to have near normal diet. Now I am falling back here. I'm going to do a clot test now. So clot test, why I'm doing is for demonstration and also to make sure this patient after H. pylori eradication, she had a close. What is its positivity? So usually you have a response of about 80 to 85% in my experience. We give 14 days of these drugs you advocate. Then, so for people to go, see the trajectory is at 7 o'clock. Okay, you have only this amount, that is only 1 centimeter beyond the metal portion should be ready, and you and your staff nurse should speak the same language. She has to listen only to my command. She should not do herself anything. Open, close. So it is open, close, then lift, okay, then you snap, then you take, but keep the view of the biopsy always. And I am not seeing her. I just did that, believing that whatever I am doing, she is responding. So she will take it. If you take the camera to what they are trying to do there for a moment, and I have Sendil from Shali. He is going to supply all these accessories today with the clot test and also all these dilators and whatever we need. And he is going to place that little piece of antral tissue onto a slide, put a small drops of saline, keep it for about a minute or so. And what is an yellow disc there, as you can see, it will turn into pink. Then pink is positive. That is the very quickest way of seeing whether the patient has a urease enzyme even present. If it is second time positive, whatever drug you have given didn't work or she didn't take. So you need to do further test, even consider doing culture and all those things. So that's about the very simple rapid urease test. We have done it. We'll go back to the interior. The bleeding is stopped. That is expected bleeding. Then I look quickly at the incisura here. This is a peristalsis. This is incisura. Incisura is a constant landmark, commonest site of benign gastric ulcer along the lesser curve, stretching between 8 to 2, and do a big wheel towards you, do a J maneuver anti-clockwise. The thing you should not do is turn this way. Say this is an awkward movement. You have a wrist strain. You don't do that. You do this movement. It is good for your morning dance and also body movement. So this is a movement we advocate. In other words, this has to, the wheel should be on your right and all the buttons should be front. This should not be done this way. This is the thing. Sometimes people inculcate these types of habit from their seniors, but I would resist doing that. You keep it always like this. And you even 100 cases you do, you don't have any wrist strain. So you do this clockwise, anti-clockwise, pull the scope and see the fundus and the fluid is there, and also you can have a cardiac pulsation there. Okay, then close to that is the cardia. What is hugging is the cardia. What is very close to the scope is a lesser curve. What is away from here is a greater curve. So you should know, describe, if you see a lesion, how far close to the lesser curve, along the lesser curve, how close it is to the OG junction. All these things you see. The last thing you do is a deflate, then you come out. Deflate and depart. That's what I say. You deflate, then you come out. Otherwise, patient will go and burp outside. So I just deflate. So distensibility, linitis plastica can be excluded in some people by just seeing how elastic the stomach. Then come back, see the OG junction and have a good look. See back again my hand here. I am hugging the scope in such a way I have a full control. The patient is not vomiting the scope. I am taking the scope millimeter at a time.
Hope you had few tips and tricks for the upper GI endoscopy in this one. But friends, please prepare to abandon the procedure if the patient is restless or not very cooperative, or in any case of cardiorespiratory issues. And also if there is any such suggestion of complications like perforation, false passage or even an aspiration, please abandon the procedure. Immediately take the scope out and call the resuscitation tube. Very, very important thing. And once you have successfully completed the procedure, it is not over there. You need to have a detailed report like what we have given here, this one. So you need to have a software where you can record all the findings and use the standard definitions and all the internationally accepted terminologies to describe the lesions, have some pictures annotated and give it to the patient or the relatives and give the detailed diagnosis and treatment plan, and also tell them, especially when they are sedated, not to have any solid food for 30 minutes, not to drive for the next 24 hours. All these instructions have to be given and also a contact number to contact you in case of any difficulty. So, ladies and gentlemen, as I just said, this is just a beginning of your journey to perfect the art of endoscopy. So, endoscopy ritual is very, very important before you embark on any basic diagnostic endoscopy, both the endoscopy checklist and patient checklist. Second thing is, during the procedure, ensure all the safety precautions are observed with a pulse oximeter, ECG and administer nasal oxygen. And endoscopic steps, as I said, it is just today you are learning the technical skills. I am sure the cognitive skills of interpreting the results and also for all the pathologies, everything is going to be in the subsequent classes you will learn, because here the training or a success, anything is just a journey, it is not a destination, because I am sure you also will accept if I say the endoscopy is the future and there is no scope without a scope. Thank you very much. Enjoy the day.
Thank you, Ishwar, for a very lucid, very elaborate lecture. You made the scopy so simple, so beautiful to look at it, and how to start it for the beginners. So,
thank you, Achal. Any questions or any clarification required? Otherwise, we'll have the discussion at the end. Achal, Satvir, nice for the introduction you gave me.
Thank you,
How
sir.
are you? Nice meeting you once again.
Fine, doing good endoscopies as you trained me, sir.
Thank you, thank you.
Very well spoken.
We can proceed to the next lecture because I think there is some time lag is there. No? The program started late.
To proceed to the next lecture is by Dr. Satish Midha sir on cleaning and disinfection of scopes, and our honorable chairpersons are Dr. Ramesh Agarwala sir and Dr. Om Prakash sir. I would request Dr. Om Prakash sir to give a brief.
Yes. Can you hear me?
Yes, sir.
Dr. Satish is well known to me since 1990s. He is pioneer of endoscopy in this whole area, Jharkhand. He started his learning from Dr. Nageswar Reddy, and he organized several conferences in Ranchi during that period. To say many things about him, you could say for half an hour. Presently, he is the president of NMO, and he is very much active in all academic activities of ISGS and JASICON and SCON everywhere. So I welcome him to deliver his lecture. Hello. नहीं सुन रहा लगता है.
Hello, thank you very much for your kind words. Respected Professor B. Krishna Rao, dear Dr. Sunil, Dr. Arunima, Dr. Om Prakash, Dr. Achal, and all others who are present. I'll just start sharing my screen.
क्या हुआ सतवीर? What happened?
Can you see my slides?
Yes, sir.
You see,
there on the screen,
we have had the glimpse of the some anatomy of the scope. So cleaning and disinfection and sterilization of the scopes is very important, and more so in the present era when we are in the COVID era. So it has always been important, like any other cleaning process. This is something which is sometimes, not always, sometimes neglected also. So we have to keep this in mind, and I'll just go through the various methods of cleaning and maintenance of the scopes. This all will not also prevent the transmission to the of the organisms to the other patients, and also the transmission to the health personnels, but also increase the longevity of the scopes. We all know that these scopes are very delicate, and they are manufactured in such a way, so they have to be kept something like flowers. We have to handle them like flowers, and we are using these endoscopes to treat and diagnose many conditions. And infection, though it is very rare, the incidence is very rare. About 1 in 1.8 million procedures is the reported incidence. But we have to keep that in mind, that how to handle these scopes. The flexible endoscopes are a very high output, extremely useful, and enormously versatile, minimal invasive diagnostic and therapeutic instruments. They are sturdy, reusable, yet expensive and complex systems. They have channels which have the higher bioload, and they are specially designed to, we have to disinfect them, and proper reprocessing is very important to maintain these scopes. Inadequate reprocessing may result in patient-to-patient transmission of bacteria as well as viral diseases, And prevention of serious endoscopic associated clinical infection requires strict compliance with the detailed reprocessing protocols by specially trained staffs. And these are the several organisms which may be transmitted, which includes various bacteria, viruses. This is the list which we are aware of, which includes H. pylori, also hepatitis B, hepatitis C, HIV. All these can be transmitted through the endoscopes.
I'm sorry to
There are various terminologies
slides
which
are
we
not
must.
moving, sir.
Hello?
Sir, the slides are not moving, sir. Can you make it full screen? Yes, sir.
So,
sir, click on resume slideshow, sir.
Yes, sir.
Now view show, sir. Slideshow it, sir, again in the down.
is it okay?
Change the slide, sir. No, sir. Can you just close the presentation and open it again? Your camera also is off, sir. You can just enable. We can see you on camera. Please open your presentation, sir. Share screen.
Can you see my slides?
No, sir. You have to select your presentation, sir. I think you have joined with web. Yes, sir. Now change the.
Can you see now?
Yes, sir. Change it, sir. Change the slides.
Is it changing?
No, sir.
No, it's not changing.
Sir, can you make it full screen and then see whether it is changing or not?
Yeah, I have made it full screen.
Yeah, it's changing. Something happened now. Now it's yeah, start.
So I'll just go on without making it full screen, I think.
Okay. Yeah, okay. Yes. Now it's changing. Yeah. Yes.
Go on.
So we have to know few definitions regarding the maintenance of the scopes. First is the cleaning, which is very important, which includes the removal of blood, secretions, and other debris from the endoscopes, as well as the accessories which we are using. And then comes the disinfection, which is the reduction or destruction of all vegetative microorganisms, mycobacteria, small or non-lipid viruses, mixed size or lipid viruses, fungal spores, and some but not all bacterial spores to a level appropriate for safe use of endoscopes and accessories in the patient. So this is the disinfection. And then there are infection control measures like disinfection of the medical equipment, proper use of the personal protective equipments, personal hygiene, engineering controls like ventilation, building designs, cleaning and disinfection of the environmental surface, adequate administrative monitoring and support, training and continued education of the staff, and adequate written protocols. This is very important. So these are the flow chart of the steps which are involved in the maintenance of scores. We need to clean them, rinse them, disinfect them, again rinse them, dry them, and do a proper storage. So all these steps are important. And if possible, Sterilization should replace the disinfection step, but this is not always feasible in case of flexible endoscopes. And cleaning must always be performed prior to disinfection. So the cleaning process includes the manual cleaning, which includes brushing, exposure to all external and accessible internal components to a low foaming enzymatic endoscopic compatible detergents, which are now available in the market. And sometimes we also go for the automatic disinfection, where there are instruments which can do all these things. And then there are guidelines to do all these procedures. And before cleaning also, there is a pre-cleaning also. We detach the parts from the endoscope, like the buttons and all these should be done, and then go for the cleaning and rinsing. And for the disinfection, we immerse the scopes and the valves in the disinfectant solution, which has a proven efficacy, and we irrigate all the channels with a syringe until the air is eliminated out, and to avoid any dead spaces in these channels. And always observe the manufacturer's recommendations regarding the minimal contact time and correct temperature of the disinfection solutions which we are using. Always observe the recommendation for the compressed air values, and always remove the disinfection solution by flushing air before rinsing it, and determining whether the disinfection solution is still effective by testing it with a test strip, so that we are using the proper solution. And then we go for the final rinsing. Always discard the rinse water after each use to avoid any concentration of the disinfection and thus damage to the mucosa. Never use the same container for the first and final rinsing. And then the drying of endoscope is very important. And then the proper storage must be done. And never store the scopes in a transport container, which we see sometimes being done. Regarding the optimal standard, we must clear the gross debris, expel any blood and mucus, flush air and water channels, check for bite marks on the or any irregularities on the scopes, and detach the scope from the light source or the video processor, and then transport in a closed container to the reprocessing room. Cleaning, we must do a leak test before the cleaning starts, because sometimes there may be some leakage also. Clean all the surfaces, use disposable brush and disposable swab tissue, and renew the detergent solution for each procedure, and clean and rinse the container before the next procedure. This is again the same thing. Regarding the cleaning, we must ensure that all channels are cleaned properly, and leakage test is again done. The next is we have to remove the biopsy valve and all these things. Water bottle suctions, they also need to be cleaned, or sometimes if they are autoclavable, they must also be autoclaved. All exposed internal and external surfaces should then be manually cleaned and rinsed according to the recommendations which are with the solutions. Disinfection should be done by the trained staff at the beginning and at the end of each patient list, as well as between the patients. So normally, if you are having too many procedures, we need to have multiple scopes, but this may not be possible in all centers, but this is the ideal situations. If possible, we should use the automatic endoscope reprocessor, performing disinfection in a dedicated area with atmospheric extraction facilities, and we must flush the high-level disinfectant or chemical substance through the endoscope at the correct temperature and at the correct duration, and the concluding disinfection by rinsing with sterile or filter water or alcohol, and dry each endoscope properly by the forced air. The final drying should be done without water, which doesn't have any microorganisms, and alcohol drying may be hazardous. Regarding storage, we disassemble the endoscope in a ventilated or a storage cupboard, ensure that the valves are dry and lubricate if necessary, and they must be stored separately. And we must hang the scopes in a preferably vertical position, remove caps and valves, uncoil the insertion tubes, protect the endoscopes from any contamination, use in a well ventilated loop. Sometimes there are also temperature is maintained by the thermostats in this storage things. There are some weaknesses, which deficiencies which can occur, which may be due to inadequate cleaning, using on the brushes are not proper, or the disinfectants or detergents which are not proper, temperature is not maintained. So these are the things which we have to the rinsing water may be contaminated. This has been seen in some of the laparoscopic units also. Mixed, if you mix the both organic material and the washer disinfection, that may also cause harm. And sometimes we use of the non-sterile accessories like biopsy forceps. They may also be cause infections. And inadequate reprocessing of the water bottles. This is again a neglected area which must be kept in mind. Use of tap waters and inadequate transport and storage. This must also be kept in mind. Then again, there may be contaminated or defecting washer disinfector, which we have to keep in mind so that proper steps are taken. And there may be some design limitations which may lead to the improper disinfection. We have to check the water supply from time to time, and the ultrasonic cleaner may also be disinfected, or there may not be sufficient drying and storage space, and we must avoid making any shortcuts to the things prescribed. The possible routes of transmission are endogenous transmission from patient microbial flora, or patient to patient transmission, or transmission from patient to the endoscopy staff. So there are various types of category of the instruments. There are some of the non-critical which come into contact with the skin but not with the mucous membrane, and they rarely transmit diseases, can be cleaned with the detergents and low level of infections. But there are some semi-critical equipments which come in contact with the mucous membrane. So all these endoscopes come into the semi-critical types of equipments. So these are our objectives for cleaning the endoscopes, that they should be without any bacteria and fungus and without any viruses. So we need to deal with the endoscopes, and these are the semi-critical equipments which need to be cleaned every time. Regarding the methods of sterilization, the normal one which we use is the chemical methods of sterilizations, and there are various solutions which are available. Glutaraldehyde is the commonest one which is being used. The other common ones are the hydrogen peroxide and the orthotaldehyde and peracetic acid with hydrogen peroxide are cleared by the FDA, and they are dependable on the high level of disinfection, providing the factors influencing the germicidal procedures are met. So all disinfection should be done at the correct temperature, and we must check the efficacy of the product which we are using. There is no ideal disinfectant available so far. These are the properties of the disinfectant which should be ideal. We should have the wide range of coverage, compatible with the endoscopes, non-irritant, versatile, and environmentally friendly, and adequate sterilization is achieved, highly potent. So we have few which are close to the ideal, but none of them is ideal. ETO again is very commonly used for sterilization of scopes as well as the accessories, and This is very much in common, but there is a safety concern regarding ETO and also is carcinogenic, so proper handling is essential. Strict regulations regarding the occupational safety must be maintained while using the ETO. Aldehydes, as we know, we are commonly using putting the scopes in the glutaraldehyde or also paraldehyde solutions, and then they must be used after this proper time, usually 20 to 30 minutes. Glutaraldehyde, again, we need 20 minutes contact, and we must have the systems to keep it for 20 minutes, and then proper rinsing is needed. The efficacy of glutaraldehyde, as we know, is 2%, ranges from 25 degrees centigrade for 20 to 90 minutes, and we must keep the adequate time. Sometimes people rush in and we do not. There are some advantages or disadvantages of this glutaraldehyde also. So there's a long list. I'm just skipping for the want of time. So it is the common agent which we are using. Orthopedaldehyde is again, which is again being used by us also. So it is a higher excellency. So stability is for about 7 to 14 days, and it is excellent compatibly with the most of the scopes. But sometimes there are anaphylaxis have been also reported with the health personnel. So we must avoid spillage on our eyes and our body so that we don't have the problems with these material. Hydrogen peroxide again has been used, and but although it can damage rubber and plastics and corrode copper and zincs, so the solution of about 7.5% can be used. Peracetic acid, that has also been used and is also very useful, and we have to change the solution every day. They are stable usually on the same day, but there are some formulations which can last longer also. So again, combination of peracetic acid with hydrogen peroxide has also been tried, and it also has been approved by FDA for the sterilization of the, and there are some emerging chemical agents, they are also being tried, like superoxide water with aqueous solutions, they are also being tried. This superoxide water, also known as the anolite, which has been processed by electrical current passed through it, thereby generating a number of oxidized species. This is an electrochemical process. Specifically, it is like a electrolysis. This is the superoxide which is being used. Then high level disinfection is required to kill all the mycobacterium species. And then physical exposure too is very important. So you can see these are the processing units in which all the steps are performed one by one. You have to just do the manual cleaning and then put the scope, and then there are, you can connect the valves. There are connectors available, and it can do all the things one after the other, including rinsing, drying, and all these steps can be met in one go. And then we have to remove the disinfectant after the proper disinfection. Then there are steris or the cold liquid sterilization. This can also be done by acetic peroxide. But these are expensive methods. Then there are emerging methods also, like ozone, vaporophores, and plasma technology. This is the gas plasma technology, which is a newer technology, which is being used in some very few centers in our country. And choline dioxide, this is again a high level disinfection, which has a high sporicidal activity, and the solution is stable for 7 to 14 days, but it is irritant to skin, eyes, and respiratory tract, and it has a strong odor of chlorine, and ventilation is recommended. So we need to have a combination of detergent and disinfection. And there are some issues with the automatic disinfection devices. They are costly, and there is lack of standardizations. There is increased workloads on the because you have to keep the scope for a quite long time, and they're more complex and require more training. And without regular maintenance of these devices, there is again an increased risk of infection. Then we have to test the sterilization activity, and that has to be done regularly by the strips which are available by the suppliers. The healthcare worker should follow the guidelines for the proper maintenance of the scopes. Sometimes we try to bypass these, which may lead to, and we must keep a log of the accountability. A record must be kept of the serial number of each endoscope used in each patient. This is important for any future contact tracing when possible endoscope transmission of the disease is being investigated. And then we have to protect ourselves from all the disinfectant, any side effects which can occur. Compliance is very important. Then there are autoclavable endoscopes which are being just thought of, but they are not still at present. Then idea of disposable endoscopes, that has also come in, though this is a very costly proposition for our country. But in some countries, disposable endoscopes, they are still being marketed. Or now there are some parts which are being disposable, like in duodenoscopes, the tip is made disposable, which is mainly responsible for transmission of infection in ERCP. So regarding take-home messages for cleaning and sterilization of the scopes, rigorous adherence to the best practices in endoscopic procedures must be adhered. Disinfection and reprocessing is essentially an assurance of quality and safety of gastrointestinal endoscopy. Reprocessing of GI endoscopes and endoscopic gadgets is safe, cost-effective, and is an accepted practice, and is a multiple step process which entails standardization and accountability and is rigorous adherence to the recommended protocols. High level disinfection with current disinfectants are satisfactory, but novel alternatives have offered better safety and acceptability. In resource scarce settings, shortcuts due to insufficient number of endoscopes and or reprocessing material should be avoided, monitored, and addressed appropriately. Thank you very much.
No. Hello.
Hello.
Yes, sir, you're audible, sir.
Satish, thank you for so much exhaustive knowledge about all these things. Thank you.
I know it's very dry topic, but this is very equally important.
Yes,
because
yes.
for the patient safety, health, personal safety, as well as.
I fully agree, Satish. It's a dry topic, and we tend to, avoid these topics. A good knowledge of the high-level infection is very important for endoscope, and we must insist that it is done by letter and spirit. You should never take a shortcut.
Sir, I would just like to put a question because we are also streaming live on YouTube, and there is a question on YouTube where they have asked that is there any special precaution when we do endoscope cleaning in COVID-19?
I think in COVID-19, we must take precautions for the aerosol prevention, whatever is essential. If the patient is highly suspicious or not screened for COVID, we must take the precautions for PPE kits and other things. Some special vaporizer, means aerosol prevention devices, they have been also designed by some of the companies, and we must protect ourselves and all the staff members while doing endoscopy. We must put in at least some guards, and especially protect our eyes, nose, and full double masking. And all staffs, sometimes staffs also, they try to neglect. They should also put some face screens, and the sterilization and disinfection, whatever we are doing, that must be adhered, because nowadays, and if you have 2 scopes or 3 scopes, it is better. If your workload is high, then you must procure more scopes in this COVID era, so that you can give sufficient time. Because if you are really going to clean this scope, so it will take at least 30 to 45 minutes to get the scope back to you. So I know it's very difficult to buy another scope or keep these scopes, but this must be done.
Please, you have so much knowledge of all endoscopes. I like that at the end of session, if you give us the idea how to procure each endoscope at reasonable price. Any idea? That should be included at the end.
That will be done at the end, Dr. Om Prakash. Yeah. We'll help there.
Thank
We'll
you,
help
thank
there. That is the vision, to train one surgeon at least in each district to the best level.
Yes.
Thank you, Dr. Satish Midda, sir. To move on to our next lecture, which is Pathological Lesions of Stomach by Dr. Satrapiya De Sarkar, sir. And I would like to invite chairpersons, Dr. Ramesh Agarwala, sir, President HSI, and Dr. Colonel S.S. Chauhan, sir, from Jamshedpur.
Thank you, Dr. Satvir. And a very useful talk till now. We have learned the basics of endoscopy, and Dr. Satish has also told us how to maintain and how to do a safe endoscopy, particularly during these COVID times, and the various precautions to take to safeguard both the doers and the patients and the support staff in these COVID times. Now we move on to the third presentation of the day, when we would be knowing from Dr. Desarkar regarding the pathological lesions of the stomach. Over to Dr. Desarkar, please.
Good afternoon. Before Satyapriyo starts, I would like to say a few words. Though Satyapriyo needs no introduction, but people who are not familiar with his name, he's from the city of Calcutta. He's in private practice. Currently, he's the treasurer of IAGS. He's donned many hats in IAGS. He's very good organizer. Now he's one of the most important persons in the endoscopic courses which are being conducted by IAGS. He has more than 1 lakh procedures to his credit, which many people do not know. And he's also very well respected by the medical gastroenterologist, and he holds many posts in their organizations. And he's a good friend, good organizer, very good person, and a good surgeon. Another is a very big philanthropist. We have seen him that he's been carrying out a lot of social activities on behalf of IGS, but he also does on his individual capacity. It's very heartening to know that he works with the children of sex workers in Calcutta and organizes funds and sports activities for them. So I often ask Satya, what do you eat? Where do you get so much time to do so many things, doing social activities and organizing things and carrying on his very busy practice? He's one of the guys who starts 7 o'clock in the morning. And whenever I call him at 7 o'clock, he's already got an endoscopy. So over to you, Satya. Not many words, but I can keep on going, talking about you. Over to you, Satya, for your presentation.
Thanks a lot. Thanks for the kind words. The respected chairpersons, special thanks to Dr. Sunil Kumar, Dr. Arunima, Sadhbir Singh, and office bearers. And it's always an honor to talk in front of Dr. Krishna Rao, who is the pioneer person, and we all, me, Shanil, Ishar, Satish, were of same generation. When we started our learning our endoscopies by fiber optics, we are actually chased out. And always special thanks to my guru Ramesh Da, who actually brought me to the national scene. Now I am the chairman of the endoscopy board. So always a great regard to Ramesh Da, and with that I start my presentation. Yes, the first thing is endoscopy, I think, is the place where the word really works wonder, that your eyes cannot see what your mind doesn't know. So you should know what the things look like, what is normal and what is pathological. Then you can venture into that. And I'm very happy to know that Shanil Kumar is trying to spread it to all the districts of West Bengal. Actually, with my persistent effort, our Chief Minister has given endoscope to all 22 medical colleges surgery department in West Bengal, the first state to have this one. So I really thank her for this initiative. And I really give all the best wishes of Jharkhand to have a fantastic endoscopic surgeons. So what we do endoscopies, we do the routine endoscopy. Sometimes yearly, twice or thrice, I'm called to do an intraoperative endoscopy when after initial diagnosis, while doing the surgery, they are not getting the lesion. And sometimes after post-operative, unexpected problem, we go for the post-operative things. So it is recommended that once you go inside the stomach, upper GI, you must wash, remove all the food residue, mucus plug should be given for the optimal visualization. See it properly, see it with passion. Image enhancement techniques are zoom endoscope with magnification, chromoendoscopy, where you stain few of the lesions and you have a better delineation, better out border markings, and you may have the electronic or digital chromoendoscopy, that is the narrow band imaging, where you take out the red light and to look into few of the fantastic lesions properly. What do you mean by the magnification with zoom technology? The magnification with standard endoscope 30 to 35 times, and magnification with zoom is 150 times. So when you are going, especially with narrow banding, and we are seeing the peat patterns and others, thinking about the possibilities of malignancy, these magnification with zoom really matters. Chromoendoscopy, you give few of the stains and then you wash it and then you look into that, but it's a very cumbersome procedure, and for different suspected lesion, you need different training. That's why people have switched over to the digital chromoendoscopy, that is the narrow band imaging, started in Japan by Professor Ken. Now that's the start. Ishar was showing him. You go behind your palate and into the pharynx. You look in front the vocal cord, the epiglottis, vallicula, you go behind and you get into the esophagus. That's a beautiful esophagus. Liquid or solid food residues are usually not there. If it is there, you have to think about some obstruction. It may be achalasia, maybe skidding, maybe esophageal stricture, but some problem is there. Otherwise, it looks so skinny after your proper preparation of 6 hours fast. These are the tertiary contractures and motility disorders. Sometimes you see very jerky, typical, unusual, persistent, these more peristaltic things. You should think about the motility disorder. Now the Chicago classification has come, which has given you a beautiful classification of different types of esophageal motility problems. But while doing the white light endoscopy, you first think. One more thing is coming for last 1 decade more and more is the eosinophilic esophagitis, where you also see many waves and rings. And if you see too much waves and rings persistently in the esophagus, take a biopsy, mucosal biopsy from the esophagus. Look for the in high power field, how many eosinophils are there, and you may really diagnose a beautiful disease, eosinophilic esophagitis, where the treatment is totally different and you can give relief to the patient. Going for the next, coming to the G junction, and the first thing you see is a hiatal hernia. See, you are in the esophagus, you can see the stomach mucosa. The mucosa is protruding into the esophagus, and you go inside the stomach, you do a retroflexion, what Ishwar was saying, you go left, you go up, and you see in the upper part, the upper left, that one is nicely grasping your scope. But in the rest others, this is not grasping your scope. There are lots of space between the scope and the G junction. And all these are different types of lower esophageal sphincter relaxation. So lower esophageal, if the sphincter relaxations are there, that initiates the reflux into the esophagus, causing very type of pathologies. Esophagitis, a very important thing. Different types of esophagitis, though we should know that the Western world, the esophagitis is much severe variety. We get the mainly Los Angeles classification. There are many classifications of reflux esophagitis. The reflux esophagitis commonest is the Los Angeles classification. The first type is from the left up, if you see, the small erythemas are there, none more than 5 millimeter, none going from one mucosal fold to other fold. Then you go, you have more than 5 millimeter going from one to other fold. Then you have more around less than 75% of the circumferential reflux esophagitis, and ultimately you have the whole circumferential esophagitis with ulcers or strictures, which are the grade 4. And these can actually predispose to the esophageal carcinoma. But luckily in our country, in my experience, I have seen the severe esophagitis are a rarity, and also turning into the Barrett's and then going for the esophageal squamous, or from Barrett's you see the adenoceae. Those are again not as much as it is seen in the Western world. Going for the Barrett's esophagitis is a very important thing. What happens? The acid comes up and it destroys the esophageal mucosa. After that, that mucosa is get healed by the gastric mucosa going into the esophagus. The Barrett's has a now Prague classification, which is now totally changed the previous one. What they are saying is C segment and M segment. What is C segment? Where there is the actual diaphragmatic opening, the G junction. From there can be circumferential gastric mucosa, which is the length we measure as C. And above that mucosa, there can be tongue-like projection going along above that circumferential gastric mucosa, again going along. There can be islands of different spaces, which are the Barrett's esophagitis. And how you say, suppose there is no circumferential gastric mucosa, so C is 0. Only tongue is present, 3 centimeters. So you write it C0, M3. When there is a 3 centimeter circumferential gastric mucosa, reflux esophagitis, Barrett's, and there is another tongue going up 2 centimeters. So you write it C3 and M2. That way, the Barrett's esophagitis is measured. Why important? The more is longer, the more chances of going into dysplasia and malignancy. That's a stricture esophagus, how it looks like. Commonest are the corrosive ingestion, and really if the patient are neglected after grade 4 esophagitis, you can go into that. You can do endoscopic esophageal dilatation with excellent dilators and really can relieve the patient without very big surgery. That's another thing, is Kett's ring. This is, they say, the normal thing. Is present in 3% of the normal population. Is nothing but a mucosal fold, but sometimes it causes dysphagia. So if you see this ring, you can make out there is no Barrett's, there is no reflux esophagitis, there is no growth there. So the patient is safe, and if needed, you can go for a benign dilatation of the esophagus. This is another very important thing, a Mallory-West syndrome. I have seen patients, especially little older patients, coming suddenly with 2-3 gram hemoglobin, and we went we have seen sudden onset, severe bleeding, patient head retching. Textbook says if they are alcoholic, if they are having continuous retching due to other causes. But I have seen the patient who are absolutely non-alcoholic, absolutely sane lifestyle, but come up with a sudden the regurgitation causes a vertical tear in the G-junctional mucosa, and that can cause severe bleeding. You can do the 1 in 10,000 adrenaline injection by side of that, and then you can jolly well wait. Almost in all cases, the bleeding settles down. You resuscitate the patient. Diagnosis is very important. And then I've seen after 6 weeks, there is no trace of anything. But diagnosis, you must think in your mind that it can happen in a few of your cases. That's the typical white flecks, multiple white flecks going around in the lower, middle, even up to the upper third. That is the esophageal candidiasis. Usually the Candida albicans is the pathogen, and the patients who are especially on steroids, on immunosuppressive drugs, even patients without that thing, a long-standing there suffering, these patients are having this esophageal candidiasis. And with the 15 days antifungal treatment, I have seen clearing, everything is clearing. So again, you must know the condition. So just by looking it, there's no other diagnosis. Coming to the esophageal varices, a very dangerous, life-threatening situation, grade 1 to grade 4, depending on 1 millimeter into the lumen 1, 2 millimeter into the lumen is grade 2, 3 millimeter into lumen is grade 3, and more than 3 millimeter into the lumen is grade 4. The more size of varices goes up, the more chances of bleeding are there. Now, if they say if there is stage 3 or 4 varices, you should go for prophylactic endoscopic variceal band ligation. It's not like before, you wait for one bleeding. One bleeding can be catastrophic in the patient with chronic liver disease, with coagulopathy, and with a huge portal hypertension. So you give your drugs and you do a beautiful endoscopic variceal band ligation starting from the G junction going up. And after 2-3, you see all these huge varices just simply disappear. This is the fundal varices, which you can see in the stomach because of the same thing, because of the portal hypertension, because of the chronic liver disease. It can be maybe even pre-hepatic cause that also can give rise to the portal hypertension, pre-hepatic, non-hepatic, extrahepatic portal fibrosis, portal vein thrombosis, anything that can give rise. Looking into the fundal varices is very easy. You do the retroflexion and see the fundal varices. But when you are going for the glue injection, here you cannot do the banding. You have to give a glue that is the nectaryl, and that nectaryl injection, positioning the needle into the fundal varices is a very tricky thing. Sometimes it seems impossible. So looking into the fundal varices and diagnosis is very easy, and sending it to somebody who is doing the therapy. For the therapeutics, the ergonomics sometimes can be really, really very difficult. But again, everything can be managed once you are up in your learning curve. Portal gastropathy is another thing you can see. It may be associated with your esophageal or fundal or duodenal varices also, isolated varices, but it is again due to the venous congestion because of the pressure on the portal radicals in the distorted and architecture of the liver. The blood cannot smoothly go there. So there is venous congestion, and that causes this typical fish, their skin-like these things, submucosal erythema. And the only important thing is you should not take any biopsy from that. It can bleed troublesome. You can jolly well make out, most of the time it can be diffuse all over the stomach. Many of the times it is in the upper half of the stomach. There's more prominent portal gastropathy. These are all signs of portal hypertension. Most of the time it is due to chronic liver disease. Some of the time it can be even pre-hepatic or post-hepatic cause. Submucosal lesion, you should not mix it with the gastric polyp. And I remember around 15 years back, some of my colleagues tried to do this polypectomy of this submucosal lesion, and ultimately resulting in perforation. It was a big perforation. We went in and then we sutured it closer But this is one thing you can see, the mucosa over the lesion is absolutely smooth. And if you can push your endoscope, you can see the mucosa moving over the lesion. So this is a typical submucosal lesion. Going for the GIST, a very important, gastrointestinal stromal tumor. It can present with severe bleeding. Most of the GIST I have found out, some are incidentally raised collar with severe hemorrhage. There can be these umbilicated type things which may be due to the ischemic ulcers on that. Then so even with one of the DD is ectopic pancreatic tissue, if they are in the stomach, that can also have this type of umbilicated appearance. But GIST, you can again understand, this is a submucosal lesion. You should never try. You can do a hybrid procedure. You can have your laparoscope in the peritoneal cavity, and you can do a polypectomy-like thing from the stomach. But otherwise, only endoscopically, don't try to take out the GIST. You will result in a catastrophic situation. So look into that, keep it in your mind so that you don't make that huge mistake. That's the gastric polyp. Different types of polyps are there, mainly sessile polyp, when it is flat and you don't get a stop, and rest others are pedunculated polyp. The beauty of pedunculated polyp, that can be huge one, but if you can nicely and skillfully pass your snare beyond your huge tumor and go into the pedicle of the polypectomy place, and you have an endocard there which goes periodically, not continuously. Those endocard is the beauty of that one, and you can take out say, a hugely dangerously looking polyp and then take it with a Roth basket, and your everything is over. And you can even use the snare clip over the pedicles. So that's the beauty of the gastric polyp. You will get lots of polyp once you start doing it regularly, and always take a biopsy. Many of them are more, I should say most of them are benign. They can be hematomas, they can be only hyperplastic. But if it is adenomatous, if it is dysplasia is there, you should not wait at all. And please take it out nicely, properly. And if you have an NBI, you can really make out what is the border of the dysplasia going. Sometimes very little, it goes even beyond your pedicle. So in that case, you do a saline lift, give little saline in the submucosal space, take it up and take the all suspicious area so that you don't leave any suspicious area after your endoscopic polypectomy. CA esophagus, different types of carcinoma esophagus are there, different grades. This is also a little late, and this one is definitely causing dysphagia. Many of the patients are very atypically, they can tolerate the dysphagia till they come the time when their mates are there, local things are very bad. So we should really motivate the person, and so that they come early. The endoscopy should not be a nightmare for them. And people also should know that when to refer, and refer early so that all the results are fine. Here we can give an excellent description. When surgeons doing this thing, they give all important surgical points like the position, the site, how much circumference it is there, ulcerations over there or not. They can make out many of these things. So these are the very important points for the surgeons to go by themselves. H. pylori infection, you all know, mainly the duodenal ulcer and the peripyloric area infection, antral infection are mostly associated. So anywhere of the stomach infection and duodenal infection can be due to H. pylori infection. The inventors actually, they got the Nobel Prize, and it was a dramatic history when one of them actually inoculated the H. pylori in his stomach, and then he has shown that H. pylori is causing the ulceration. The age-old Schwarzian ulcer, no acid, no ulcer therapy have been demolished by this H. pylori. And we know, and also Ishwar has shown how to take a biopsy. Always take a mucosal biopsy from 2 centimeters circle. If you draw a circle with your center at the pyloric opening, 2 centimeters around that, take a biopsy from area. One more tip is, if there is ulcer, don't take your biopsy from any pathological area, from the erythematous area. What they say, though these erythema, these infections are caused by H. pylori, the infection, but what happens once the pathology is there, this situation becomes not good for the H. pylori, so they shift from the pathological area to the normal area. So if you take the normal area biopsy, your chance of getting H. pylori is much more. And then there's a Deulefoy's lesion, a very uncommon lesion in the stomach. Usually the vessels which coming from the serosa, as it penetrates into different layer, into muscular, into submucosa, into mucosa, they always become shortened and loses its width. But very rare occasion, with the same width as it was outside the serous, it goes inside of maintaining the same width, same force of bleeding, the blood supply into the mucosa. And now they are, because of the foods and others, they are now subjected to friction and all these things, and that can take out the blood vessel which is there and can massively bleed. The problem with Deulefoy's lesion, once the bleeding stops, the vessel collapses, it becomes very difficult. You should have a very high level of suspicion and knowledge. Then only you should go and diagnose the Deulefoy's lesion, an important causes of massive GI hemorrhages. And coming to the last, going for the duodenal ulcer, that's the chronic duodenal ulcer. You can have the acute duodenal ulcer. You should always describe whether it is in the first part or second part or junction of first part. First part always should be made into two parts. First bulb of the duodenum, first inch of the first part, that is the bulb of the duodenum. So it is either bulbar ulcer or it is post-bulbar ulcer. It is acute ulcer where this is a slough. You see the white things, these are the slough. That is the indication of the chronic ulcer. Whether it is acute ulcer, whether there are chronic ulcer, it is in the junctional area or it is the pyloric channel area. And if there are numerous ulcers up to D2, D3, think about the Jollinger-Weisselm syndrome also. So that is due to the pancreatic small peptide tumor. So there are many others are there, but I thought as it is a basic course, this is a course where we want to inspire people that we have done our job with all the world against us. We inspired by Professor B.R. Krishna Rao, and you should be inspired by us. We did a little one. As Isha said, the journey is endless. We are going step by step. I'm pretty sure I can see my next generation, my students will go up much higher in the ladder. So with that, I really say only few points. Forest classification, another very important classification. That is the bleeding. You should know endoscopic classification. The typical thing in all the classifications, if you go up, the thing becomes severe. Forest classification is the only other way. When 1A is arterial spotting hemorrhage, 1B is oozing hemorrhage, 2A is visible vessel, 2B is adherent clot on the vessel, 2C is dark base and hematin covered lesion, and 3 is lesion without active lesion. So as you go up, your situation improves in this forest classification. And that's one thing where you can see how it can spot. It was spotting from a gist. It was done by Dr. Borgaukar. He has shared me this one as a great extraordinary bleeding which he has encountered at midnight. And then they have done the endoscopy procedures, injections, and APC and others. And you can see what a fantastic endoscopy can do. Everything is stopped, is clean. And later you have now all the time in the world to do the necessary investigation and go for a suitable surgery. And that's after the surgery they have done, taken out the gist. It was a gist bleeding. So concluding things, sir, give a thorough use of defoaming agents, optimize the visibility. Image enhancing techniques should be applied depending upon the familiarity and availability. You should be little familiar. You should have a monitor always to improve. Narrowband imaging with magnification is the best solution for the characterization of the lesion. And now I have to take out the endoscope to give space to the others. Thank you, everyone, for the patience here.
Thank you very much, Satya. Excellent presentation, as always. If there are any questions, I think, Sunil, you will be having those questions. You can, I can't see anything in my chat box, so you can answer. Satyapriya can answer, or you can take the questions at later date, whatever Sunil.
Yes, sir. Actually, it is the Zoom link is only for the faculty and the chairperson. So there are questions on the YouTube. So I would just put that question.
Yes.
There's a question: how to differentiate Barrett's esophagus from grade C or grade D reflux esophagitis?
Reflux esophagitis is a erythema. It's a typical erythema going from the G junction going up. Barrett's esophagus is the lesions were there, infections were there, that was healed by the gastric mucosa. The squamous epithelium is replaced by the cuboidal epithelium of the stomach. So that's a basically totally different thing. And reflux esophagitis is directly not a pre-malignant condition, but Barrett's esophagus is a pre-malignant condition. And if it is more than 3 centimeter or 2 centimeter, you should take the tissues for biopsy to see the early dysplasias are there or not. So Barrett's esophagus can never be mixed up with the grade 4 or 3 reflux esophagitis. The whole look is different.
Yeah, that's very well point, Satyada. But long-standing gastroesophageal reflux disease or reflux esophagitis can lead to metaplasia and lead to Barrett's.
Yes. That's a precursor. Because Barrett's also happens due to reflux.
Correct.
All our pathologies reflux.
I think, thank you very much, chairpersons and Dr. Sarkar, for this wonderful presentation. Before we go on to our next session and Satvir calls our next speaker and chairperson, I would just like to welcome Dr. R.P. Srivastav, who is our patron of the ASI Jharkhand chapter. It's very late night in US, but he is still logging on and encouraging all of us. I would just request him to say a few words before he actually leaves the meeting. Yes, sir. RP, sir.
Dear friends, respected Dr. B. Krishna Rao, he is still on. I had seen in the participants. Sunil and Arunima, your efforts well supported by Sadbir of reinforcing the endoscopy in Jharkhand scenario. I recall that when it was Bihar, in South Bihar, Bokaro, Jamshedpur, and Ranchi were only centers. And this I'm talking 21 years back. Still, I find that these are the only 3 centers. Well added in this is Satbir, who has started in Hazaribagh. But this endeavor, this effort of yours, Arunima, as chairperson of the chapter, and giving the tool in the surgeons, as pioneered by Dr. B. Krishna Rao, whom I always adore and appreciate for this, because even I was inspired by his motivation. And that's how we had started in Bokaro General Hospital, where the scope was in the hands of Department of Surgery. And later on, it went to Department of Medicine as well. They became the co-operator, but initiated by Department of Surgery. I will only foresee if we can inspire at least somebody in Dumka region, Dumka Deoghar, Giridih, we can inspire somebody in Daltonganj, then at least 2-3 more centers coming up in the scenario of Jharkhand will be a real, a great product of this conference. So having done this conference so excellently, let us all make efforts and see that the finances from the scope guys are well told to our surgeon colleagues, and surgeon colleagues are inspired to be trained wherever we can sponsor a Jharkhand chapter of ASI. And there are n number of people, friends all over the country who are willing to do that training part, and see that this percolates, this trickles down to the corners of Jharkhand, so that the facilities come at Galore at a stone throw away distance to everyone in the state of Jharkhand. That's my dream. And I think you people are the perfect people to realize that dream. We will leave no stone unturned to see that this happens. Bring you greetings from the west coast of US. I'm away from you. You people all have been saved by the Almighty from this pandemic. I'm thankful. और मेरी उनसे ईश्वर से मेरी असीम प्रार्थना है कि सबको वो ठीक रखें. Everybody should be safe. I'll be joining the bandwagon in the end of this month because my flight is getting rescheduled and rescheduled. So I'm now rescheduled for the last week. Let's see how fast can I join the people, my friends, my family there.
Thanks,
Thank you
RP.
very much.
Thanks, RP. It was very nice to see you. Nice mustache. Huh?
Yes, the pattern has to be going in the way Sunil is. The only thing is it's nice, but it is also showing the age. So accept that. Right.
Thanks.
Thank you. Thank you very much. Thank you. Thank you. Thank you all. Bye-bye.
Thank you, sir. Satvir, I think we can go ahead with the next talk by Dr. Roy Sunil Patankar.
Moving on to our next talk on therapeutic endoscopy in esophageal diseases by Dr. Roy Sunil Patankar, I would like to invite Dr. Sarfaraz Ahmed and Dr. Jugal Kishore Chaudhary as chairpersons.
Sarfaraz is not
Dr. Sar,
joining.
yeah. So Dr. Jugal Kishore Chaudhary is there. That's okay. Sunil sir, I request you to introduce Dr. Roy Sunil Patankar, please.
Yeah. Okay. And Dr. Roy Sunil Patankar doesn't need any basically introduction. It's not customary to say, but he's such a dynamic, lovable person. And he's the director of Jain Hospital. And he's very efficient, effective, competent surgeon, and equally competent endoscopist. I have visited his center where, ASI training for endoscopy. Man always on the move, a great guy, and a very dynamic guy. I can see him in the future, lot of accolades coming his way, and also a dear friend. So to you, Roy, for your lecture.
Thank you, Sunil, for the very kind words. And I appreciate the efforts that Sunil Bhai and Professor Arunima Verma and Jharkhand State Chapter have been done. In fact, it is surprising the first state chapter that's taken on a pure endoscopic CME, for which I think I applaud you. I have been asked specifically to speak on therapeutic endoscopy of the upper GI, excluding GI bleed, which I believe there is a separate lecture for. This story really began in 1806 when this rigid endoscope was first devised by Philip Bozzini, but really what revolutionized it was fiber optics. There was the Indian contribution to this, but Basil Hershowitz in the US first published in Lancet in 1961 an endoscopic examination of the stomach and duodenum. So this is how the future has gone. We have wonderful new things. This is going to be purely a video lecture. I'm not going to give you statistics. I'm not going to give you papers. I'm just going to show you what a surgeon can and should be doing in his routine practice. We have various ways of dilating the esophageal strictures, which are benign. And we have three choices. We have a CRE balloon, we have a Savary-Gillard, and many times you'll have this food boluses getting impacted that you can see in this video. And I'm going to show you a simple CRE balloon. Now, the trick of the CRE balloon is you don't need a C-arm, although it's ideal to have a C-arm on this. This is what we call a TTS balloon dilatation, a through the scope dilatation. You see a large food bolus on top of a esophageal stricture. The first thing you will try and do is just push it down. Actually use the scope to push the bolus into the stomach. And usually once it goes into the stomach, then it will pass down the pylorus and duodenum quite well. If this is not possible, then what you need to do is to first extract the food bolus like you see me doing here. And after, you can use a rat tooth forceps or a foreign body forceps to remove the food bolus or disimpact it and break it into parts to take it out. Once this is done, I'm putting in a Rothnet basket. This is a basket called a Rothnet, which will go in to hold the food bolus. You can also use the Rothnet for polyps, which I will show you later in this lecture, to remove polyps that have after you've done a polypectomy. And once this is done, this is extracted out along with the scope, and then you will go down to see what the cause of the narrowing is, which is a stricture. You see here, as I'm going down, you're seeing a stricture in the esophagus. This is the typical appearance of a benign stricture. It is smooth, the mucosa does not show infiltration, and it is just above the OG junction, clearly indicating that this is a peptic stricture. You will, of course, biopsy this as a matter of abundant caution. But once the biopsies are done, then I will put in a CRE balloon like you see me here. It goes in under vision and then you expand the balloon. This does not need a C-arm and can be done by the average general surgeon doing endoscopy. Extremely safe procedure. Be a little bit careful about malignant strictures because malignant strictures, particularly the larger ones, must be done under C-arm control, and there is a small risk of perforation when you're doing a malignant stricture dilatation. Important to actually hold the balloon open for a while so the stricture completely opens up, and then you will deflate the balloon and take out the balloon and then go in beyond this to confirm what the stricture looks like. Anything close to the CO junction, it's important to do a J position to rule out what is called a pseudo-achalasia to make sure it's not an adenocarcinoma of the OG junction masquerading. This is the stricture that is seen after dilatation. So after the dilatation is over, this is all the food bolus. This is not candidiasis, but this is how a CRE balloon dilatation is done, which is probably the simplest procedure a surgeon can do in his practice. We have various kinds of boluses that we will see, but like I said, I'm not going to show you this video. It's pretty similar. The first choice is always to push the bolus down. If that doesn't work, break it into pieces and take it out with a Rothman basket. The second principle of endoscopy is even if you dilate a stricture, it is important to complete the endoscopy in all patients. You must go right down to D2, D3. So this is nice, a beautiful smooth stricture seen just above the OG junction. It's not a Schatzki's ring. You can see the esophagitis there, indicating that this is secondary to a long-standing reflux. Now these are strictures which you can just push your scope and dilate it if it's a soft stricture, but the bigger strictures may need a balloon dilatation that you can see me here. Our policy is that if a stricture, after stricture dilatation, we will put them on double dose PPI along with sucralfate and give necessary dietary changes. If the stricture reforms, then I would do a repeat biopsy of the stricture to rule out malignancy, but I would also do a Canacort injection, injection of steroids 4 quadrant into the stricture to make sure it doesn't close down. If the stricture closes down after the Canacort injection, then I would put a removable stent, which I will show you a little bit later. We have a large experience of these strictures primarily because we do a lot of esophageal manometry and pH monitoring. And we are a referral center for esophageal manometry in the west of the country. We get referred a lot of patients of strictures and reflux. The next videos are about stenting. As I told you, in peptic strictures which close down, the first thing is to do 4 quadrant Canacort injection, double dose PPI. If it closes down, then we will put a what is called a removable stent. And this you will see on the right hand side of the video only from the 1st of March this year. And I will try and play both the videos simultaneously. So you see both. So these are new removable strictures which come with a little lasso at the top. And when you pull the lasso, it tends to close down. On the left-hand side is deploying a removable stent. On the right hand is removing a removable stent. So this stent we usually keep for 6 to 8 weeks to 12 weeks. Keep the patient on double dose PPI and dietary advice. When you're removing the stent, you must go in through the stent to go down, confirm the stent is open. But my advice to you is do not keep these stents more than 2 months, because then you may have some mucosal ingrowth into the stent, and these can be a little bit difficult to remove in that case. On the left-hand side, you can see a tight stricture there. I'm now taking it out. I'm loading my stent in place. The guide wire goes in. This obviously is done under C-arm control. And then you will dilate the stricture and then put in the stricture. On the right-hand side, you see me holding the lasso. This is called a lasso of the stent. It's a proline stitch attached to the stent. I am using this. I'm using a rat tooth grasper to pull on that quite hard. And as it's getting pulled, the stent will start collapsing and you will be able to extract the stent. The stent is usually taken out along with the scope under vision like you see me doing. On the left-hand side, you see a guide wire going in, and this guide wire is tracked under a C-arm. I would advise all of you to buy a good quality C-arm because imaging in these patients is important. We place little 11 number stab knives on the chest of the patient outside to mark the position of the stent, to decide how big a stent to use and how it is to be deployed. And then we will deploy a stent under C-arm control. So this is an extremely useful and fairly simple procedure to do. On the left-hand side, you see a removable stent. You see the lasso, which I'm pulling on the right-hand side. And once this is done, the stent is fully deployed. I then go through the stent. Remember, you will always check with the C-arm. Some of these stents, the lower end will lie below the OG junction and may cause some reflux. So if the lower end of the stent is actually in the stomach, remember, you need to caution the patient that he will have some reflux for about 6 weeks to 2 months while the stent is in place, and he needs to follow dietary advice and not lying down after a meal, taking a double dose PPI, etc. So this is how these are done. The next is achalasia endoscopy. Now, on the right-hand side is a picture of a very bad achalasia. This patient was referred to me for a surgery, and it's our policy to routinely do, this is my manometry catheter, which is getting coiled in the esophagus. I was unable to pass the manometry catheter into the stomach. So remember, you may get fallacious pressure readings because the manometry catheter coils up on the lower end of the esophagus. On the left-hand video is a rigiflex dilatation done for achalasia. And the typical way it's said is there is a pop. You get a resistance at the OG junction and then a pop. It's very important to see the OG junction from inside, doing a reverse or a J maneuver to rule out pseudoachalasia, which is adenocarcinoma of the OG junction. And this submucous teethering often causes a picture very similar to achalasia, which is called pseudoachalasia. Now I'm going to show you the top right-hand video, which is an intra-op endoscopy. Now we have done more than 200 achalasia surgeries. It's probably one of the largest series in the country on this. And we will always do an intra-op endoscopy. You see the trans-illumination of the mucosa confirming the completeness of the myotomy. It does two things. The scope is going down, confirming there are no muscle fibers left. And then I'm actually doing a leak test. I'm putting the patient into a head-down position and then flooding the OG junction with water and then checking to make sure there is no leak seen in this. On the left-hand side, you're seeing a guide wire going, and then I'm going to position my rigiflex balloon across the achalasia, and then under C-arm, I'm going to watch as the waist is dilated. Now, a couple of things we have learned is that we will do balloon dilatations only in elderly and unfit patients. In young patients, the choice is, or a fit patient, not young, any patient fit for anesthesia should either have a Heller's myotomy or a POEM operation, both of which we do in fairly large numbers. If you do a Heller's myotomy, you must do an intraopscopy for three reasons, in fact. One is to check the completeness of the myotomy. Number two, look for any microperforations that you see and do a leak test. Our policy after doing intraop endoscopy is to remove the nasogastric tube on table, and we feed the patient within 4 hours and discharge within 24 hours. We don't leave intra-abdominal drains. We don't do dye studies post-op. And this has been my policy for the last 10 years, that rarely achalasia stays beyond 24 hours. But for this, it is very difficult to coordinate with a gastroenterologist to come into OT to do your scopy. So as a surgeon or a GI surgeon or a laparoscopic surgeon, you must be able to do at least diagnostic gastroscopy and diagnostic colonoscopy. We also do a lot of lap anterior resections and colorectal surgeries, and many times in small polyps and small malignancies, we don't feel the tumor on table. So you may either have to do an India ink for these patients or do an on-table endoscopy just to confirm that the polyp is found. Now it's important in achalasia to tell the patient that you will do a graded dilatation. You will not try and get a full waist obliteration on the first sitting. What we do is to do a rigiflex, dilate the waist 70%, and then call the patient back for another sitting after 6 weeks. There is a large study by Bookstein in the New England Journal of Medicine saying that all achalasia dilatation must be a staged or a graded dilatation. This is extremely important that we should remember. Like we get polyps of the lower GI tract, you may also have polyps of the upper GI tract. Now, these are two videos, one in the stomach and one in the duodenum. Contrast this with very small metaplastic sub-centimeter polyps, and those are usually linked to long-term use of PPIs. Those we will simply biopsy to reassure the patient and try and get him off the PPIs. What you're seeing here on the left-hand side is a fairly large 2 centimeter gastric polyp on the lesser. The patient had presented He was an elderly man who came with occult blood positive. I will routinely do a narrow band imaging in these. I see me doing here. Narrow band imaging, as Dr. Satyapriya Desarkar has said, is use of blue light endoscopy. What we are using normally is xenon light, but all the high-end endoscopes have blue light, which is monochromatic blue light, and you're looking for the pit pattern, the foveal pattern, and any neovascularization to try and predict which of these cancer polyps are likely to be malignant. If I suspect they may be malignant, then what I would do is give a submucous injection of saline adrenaline, or I would put in some gelfusin in that to lift the polyp up, and then do an endoscopic mucosal resection. If on the other hand, the narrowband imaging shows that it is likely to be benign, then I'm going to do a straightforward polypectomy like you can see me doing in this patient. I am quite liberal in using adrenaline in these patients to lift up the polyp and to take care of any bleeding. I also recommend that you should have a polyp, a clip standby. Slightest bleeding, we put a clip and then send the patient home on OPD basis. If you don't use a clip, then obviously the worry is that you may miss a bleeding, and the patient may need to be observed post-op and may have some bleed in the post-op period, which is a concern. On the right hand is an awkward site of the polyp, which is in the D1. And you can see polyp snares are going in after adrenaline injection. I use gelfusin mixed with adrenaline. And then it's good to have a good current, good cautery. I use a Irby cautery with a pulse or a spray mode. On the right hand side, I'm using methylene blue with gelfusin and a small dose of 1 in 200,000 adrenaline to lift the polyp up. Remember, the stomach has a thick wall. The duodenum has a very thin wall. So if you accidentally take full thickness of duodenum, you land up with an iatrogenic duodenal perforation. So this trick of using methylene blue with adrenaline or gelfusin helps to lift up the polyp. Also gives you a good hemostasis at the base when you're doing this. So these are little tricks when you're doing polypectomies you can then remove the polyp either with a polyp snare that you can see me doing, or sometimes I use a Rothnet basket, which I showed you a little earlier when I was extracting a food bolus. So these are two ways of extracting a polyp. You can see the polyp. It's extremely important that this polyp must be examined on histopathology and extracted. I've taken out this polyp. This is approximately a 2 centimeter polyp, and this is how the videos run. My last video, I think, is of for some reason the video doesn't appear to be running. It's an endoscopic mucosal dissection. This is two things we do. One is endoscopic mucosal dissection we do when we are concerned that on a narrowband imaging, either we have found a malignancy, or on NBI we suspect that there is a malignancy based on this. So this is called endoscopic mucosal dissection. I'm sorry, this video for some reason does not appear to be running the way it want to. So these are basically some of the principles of therapeutic upper GI endoscopy in a non-bleed scenario. I'm aware that there is another speaker who's going to cover upper GI bleeding, and I would hand over the floor back to Professor Sunil Kumar. Sunil, it's great to be with you, and thank you for inviting me.
Yeah, thank you. It's always a pleasure. Arunima, is there any question in the chat box or whatever you want to ask Sunil? Wonderful video. You can see he does EM, endoscopic mucosal dissection, OM, and also the laparoscopic myotomy. And he's very helpful in the sense any person, young surgeon or endoscopy, he has got a lot of training programs. So, if anybody wants to go to Mumbai when the COVID is free, he can always go to him through me. We can channelize that.
I will be very happy for that, Sunil. Please let me know if you have any young aspiring trainees. All I would say is they should have some basic training there and then come to us so they can get the maximum, and we can definitely help them get trained here, both in basic lab as well as endoscopy.
We'll give them basic training here, and then if they desire, they will go. Anything else from your side?
So there is one question which is not particularly for the therapeutic part, but it's asking, is anything called nodular esophagitis? If anyone wants to answer that question, that's fine.
Sunil can answer. Roy can answer.
Nodular esophagitis is a vague term, Dr. Arunima. I don't think there is such a pathology. I think nodules can be seen either in GIST or in esophagitis in various pathologies. So nodular esophagitis as a condition doesn't exist.
And so there's another question which is on GI bleed. So we'll take it when the speaker has spoken. So
what I
we'll
want to
keep.
just say is sometimes you may have a patient coming with dysphagia who has a normal endoscopy. So there are two things the audience did. One is endoscopy negative reflux, and the second is a condition called eosinophilic esophagitis. In the extreme cases, you have what is called trachealization of the esophagus. But if you have a patient of dysphagia with a normal endoscopy, before you label him as functional, please take multiple biopsies of the esophagus and ask your pathologist to look for eosinophils in submucosa. So that's, I think, we need to emphasize that.
Thank you, sir. Yeah, Satvir.
Thank you, sir. Moving to our next speaker, which is Dr. Professor Subhash Khanna, sir, and he will be speaking on endoscopy in bariatric surgery. I would like to invite chairpersons Dr. Srijoy Patnaik, sir, and Dr. Arunima, ma'am. And I would like to request Arunima, ma'am, to please introduce Dr. Subhash Khanna, sir.
I don't think we need any introduction for Dr. Subhash Khanna because he is quite well known both in laparoscopic field and in the endoscopic field. But just a brief introduction that he is the head of the Department of Minimal Access and Endoscopic Bariatric Surgery and GI Surgery at Swagat Super Speciality Surgical Institute. And he's also the Managing Director and Chairman of Swagat Hospitals Private Limited. He has multiple positions that he had held in the past, and as far as endoscopy is concerned, he has been the president of IAGES, and he from Northeast, I think most of us know him as a great endoscopist, and he has been propagating endoscopy among surgeons. He has got multiple publications, more than 30 in his names, and presentations more than around 50. So without wasting any more time, we would request Professor Subhash Khanna. And we have got Dr. Srijoy Patnaik, if he wants to say anything. Sir, you are there. So please unmute yourself and say a few words.
Good afternoon, everybody. And we have a prominent person like Dr. Subhash Khanna, who happens to be almost the king of Northeast. Everybody knows him from Guwahati, and he was the past president of IAGS. And nice to have Dr. Khanna amongst us. We know that bariatric surgery not only will do laparoscopic surgery, but endoscopy has got a role to play, just like it has been used mostly in BMI around 35 to 40, not in super obese, but there are a lot of procedures like sleeve, endoscopy sleeve, gastroplasty, balloons and all, and we'll be waiting for Dr. Khanna to highlight more on what is the role of endoscopy in bariatric surgery. So over to you, Dr. Khanna.
Thus spoke the king of Odisha.
Dr. Khanna, please. Over to you.
Thank you, Arunima. Thank you, Dr. Srijoy Patnaik, for that kind introduction. Good afternoon, everybody, and good afternoon, chairpersons. Allow me to share my screen, please.
Sir, please try.
Yeah, is it okay now?
Yes, sir, we can see your screen.
All right. Yeah, 1 minute, please. All right. So in the next 20 minutes, I will be giving a small overview of what is endoluminal bariatric surgery. I am not going to cover endoscopy in a bariatric patient. That's totally a different subject. So I will be only restricting myself to what are the procedures which are being used at present endoscopically to for bariatric purpose and metabolic purpose. When we say endoluminal bariatric surgery, what we mean is if you are using any device that is placed or removed with the help of an endoscope, or any procedure where we use a flexible endoscope for the management of weight loss or treatment of glucose intolerance. We all know that bariatric surgery is a well-known, established, and best-known treatment for obesity at present with wonderful results, and almost there are multiple meta-analyses in support of that. But at the same time, we also know that the cost of bariatric surgery is very prohibitive. Only 1% of the people who really need bariatric surgery can afford to have it. it's a permanent treatment. It's not totally irreversible, and so at times, most of the person, they look at a reversible option. A patient always has in the back of the mind, can I go for a safer, less expensive, and reversible option? At the same time, there are many anesthetic issues. We know of cases who have to be in the hospital for reducing their body weight to optimize the body weight, where there is a role of some other alternative therapy by which we can bring the patient, we can optimize the patient and make him operable. There are issues of surgery. You need to have a spatial instrument, spatial length trocars, spatial long telescopes. So many spatial ORs and spatial operation tables. So there are many issues when you're taking a patient for bariatric surgery. Not only that, there are also complications. Today, when we do a surgery, or when we look at the literature, we see that the mortality rate is to the extent of 2%. It may be 0.5% in the best of centers in the world, but then we cannot afford to have a 2% mortality in any center across the country or in the world. So here lies the importance of endoscopic bariatric surgery. Patient's prospect is also different. Some people, they do not want a total weight loss. They are happy with a BMI of 35 or 38. They just want to bring their BMI down by 3, 5, or 7. That's one. And then sometimes they want a short-term reversible therapy. I have 2-3 patients. They are film stars, and because the lady has to look like a schoolgirl, so she has undergone a endoscopic therapy. So as I said, personal goals may be different. They might be looking for short-term reversible therapy, and most of them, no one wants a knife to be put on their body. So many of these people, they are looking at alternate options. Can we give them that option? As I said, surgeons also are at times perplexed. We all know that there are various established bariatric procedures, but when we look at the debates, the surgeons are also different. Someone prefers Roux-en-Y, someone prefers sleeve gastrectomy, someone prefers. So there are various options of surgery. The way the hernia surgeons do it is a surgery of their choice. Similarly, the bariatric surgeons differ in their choices. At the same time, many times a bariatric surgeon also feels and wants to answer himself whether I'm right in doing this procedure, or is this procedure safe in this VVIP which I'm going to do, and will it cause a malnutrition? So these are the perspectives for the surgeon and the patient and the anesthesia that we need to look into the alternative, and the alternative is what is presently has been given to us with the help of a flexiscope. In 2019, the American Society of Gastrointestinal Endoscopy in the position statement has very nicely stated endoluminal bariatric therapy in conjunction with multidisciplinary weight loss program may be accepted for long-term weight treatment. So on principle, in the position statement, the society has also accepted. There are various literature is full of endoscopic therapy options, full of work on various endobariatric procedures and devices. Now, at present, there are 5 standard indications. Early preemptive intervention in those patients who do not classify for a bariatric surgery, but they want weight loss. Overweight, but they do not classify, their BMI is not that high for any bariatric surgery. There's an ideal candidate. Bridge to surgery, which I said, if a BMI is very high, he's a super obese and not fit for surgery, you can always prepare him, whether he's for bariatric or non-bariatric surgery, you can always bring his weight down. Primary metabolic therapy, a patient is so this is one indication, particularly mucosal resurfacing is one that is entirely only for metabolic therapy. As a primary bariatric procedure in mild to moderately obese patients, can we do that with giving the competitive results? So this is also being promoted by some. And finally, one of the strong indication, if the patient has a failed bariatric surgery, can we look at an endoscopic option? I won't go into benefits of bridge therapy. We all know patient's cardiovascular system improves. Operation becomes practically easier. His liver volume shrinks, and he becomes his post-operative morbidity and mortality lowers. The way we have indication for bariatric surgery, similarly, the same approach is there in endoscopy. Either we try to delay the gastric emptying, or we try to make the gastric volume small or reduce the gastric volume, or finally, we can also go for malaparatory procedures. Of the various endoluminal devices available, the standard 6 of which most of these are, at least 3 of these, or 3 or 4 of these are already FDA approved, are space occupying devices, various types of devices starting from balloons and other similar devices, restrictive procedures, making endoscopic sleeve gastrectomy, bypass liners, which are there for malabsorption, electrical stimulation. It was a procedure of the past, but the renewed interest has been seen where we want to stimulate the lesser curvature of the stomach, and can we inhibit the motility of the stomach, or can we give some stimulus, the CNS of the patient. Aspiration therapy, I'm coming to that, and other therapies, I'll just come to those therapies. Some of these procedures are temporary, and if you are doing an endoscopic sleeve gastrectomy, you might have done a permanent procedure. Thus, we have a reversible and irreversible procedure. Of all these devices available for endoscopic bariatric, we have different types of balloon, Orbera, Helisphere, Reshape, Duo, Avalon. Then we have other space occupying devices like a shuttles or Satisphere. I'll just show a clipping of that. So those are the different types of space occupying devices. Then the restrictive procedures, we have endoscopic sleeve gastroplasty, where we use a device called Apollo Overstitch. We have O's, where we use a platform called incisionless operative platform. Endoscopic gastroplasty with toga, circular endoscopic stapler, ACE stapler. Then we have the different bypass liners, the electrical stimulation, and rest I think I have already spoken. Now, delaying gastric emptying is seen to be slightly superior to nutritional therapy, not much. What we do here is we inject 250 units of botulinum toxin around the pre-pyloric region and try to delay the gastric emptying, but a very high dose of botulinum toxin, Botox or botulinum toxin is needed. It increases early satiety and increase in delay in gastric emptying rather. There have been various studies regarding this, and most of these studies have shown a delay in a lowering of the BMI by 3 to 5 only. I will not go into gastric electrical stimulation. Here we put an implant, in fact one which will give the signal and another one which will trigger, and the rationale behind this is that the application of an electrical current can interfere with gastric motor function or moderate affect signals to the brain or both. So, but then we do not have very large study on this. How can you reduce the gastric volume? So this is done with the most popular devices called intragastric balloons. The balloons are of different types. The upper three, the Reshape is a double balloon, Orbera is the intragastric balloon system, single one, and Avalon. These three are already FDA approved, and they are kept for 6 months. Sparge is a balloon which has a small limb. It can be always inflated with an additional saline or what we are using. And ellipse is a swallowable balloon which degradates on its own, and transport shuttle, I am coming to that. So these balloons can be filled from 400 to 900 ml. They are mostly kept for 6 months, except the sponge, which is kept for 1 year. The technique of introduction of sponge is also different. Once they are in the stomach, they And that's the technique of removal of implantation of the balloon. In all cases, we do a pre-procedure endoscopy to rule out an ulcer or a hiatus hernia or excessive erosions or a presence of a pathology. In the presence of any of these, we will never go with an intragastric balloon. Once you are satisfied there is no pathology and patient is ideal candidate, we can go under sedation, we can go under anesthesia also. The balloon is introduced, either patient is introduced with the patient under sedation or just directly lubricated balloon may be introduced, or you can also pass it attached to the tip of the scope, where the scope just follows the balloon. Once inside the stomach, the balloon is inflated to about 400 to 550 ml. This is typical of the Orbera balloon, and you can see the inflated balloon there. The balloon solution is made with with 500 ml of saline, and 2 to 10 ml of methylene blue is also mixed with this saline, because in case there is a rupture of the balloon spontaneous without the knowledge of the patient, his urine will become green, and the patient is always warned that the moment you see the urine to be green, you just come to us. Extraction of the balloon after 6 months is difficult. The balloon either becomes very soft or sometimes become very tough. So we always do under anesthesia, although it's a very simple procedure, but very difficult. All the people who are doing intragastric balloon will agree with me that there are special extractor to take it out, and you can see this lot of fluid coming up along with the balloon, and the patient may aspirate. So I always prefer doing a extraction under anesthesia. Overall, marked short-term weight loss, very minor complications, nausea, vomiting, or a little bit of pain, very safe. Hardly there are 1 or 2 articles in the world literature showing a gastric undergoing a spontaneous rupture and causing a bowel obstruction. The next is swallowable balloon, where you can use 3 balloons. There is these balloons are introduced and can be removed at 12 weeks interval. This is a gas-filled balloon where a patient swallows the balloon, and the balloon can be inflated from outside with a small sting is attached there. Here you can see that from outside you can inflate the balloon. The pilot study in Europe had shown extra weight loss of about 36% at 12 weeks interval. Results of a large European US study is awaited. The swallowable balloon, the third one is the ellipse. This balloon can be swallowed, where again there is a small attachment by which you can inflate the balloon. The balloon degrades on its own and spontaneously is passed out at 4 months. It is a very small polymer surface thin layer, so it doesn't cause any obstruction. The total weight loss of 6% has been seen in the pilot studies, and extra weight loss of 25.4% is shown. So this is the steps of the ellipse gastric balloon. I don't think we have time to go through all the details of this. In meta-analysis of intragastric devices, particularly the balloons, have shown a mean change in weight of 15.7 plus minus 5.3 and drop in BMI of 5.9 plus minus 1. Some of my patients who have, you can see that BMI, the weight at July is 113, and then in the next 3 months she comes to 92, and from 110 kg she comes to 92 from May to 3 months time. So there are many patients who, one of them, they do not want to share the image photographs and see this patient who had a remarkable response from 93, she became 70 kg, she from a neighboring state. The transport shuttle, we use a device of 55 millimeter size, which is also introduced endoscopically inflated, but it has a heavier, smaller cylindrical device attached to it, so that it goes into its plate duodenum, and whenever the patient takes a meal, it intermittently obstructs the pylorus and thus causing a satiety and fullness of the stomach and delaying the gastric emptying. If extra weight loss at 3 months has been shown to be 25%, and at 6 months 50% with the device. But the device has there have been some instances of severe cholangitis and liver abscesses. That's why it's not very not very popular like the bypass liners. Diurnal flow restrictor is yet another device where the gastric emptying is delayed with the help of this attached mesh-like multiple mesh-like bulbs, which inhibit the which delays the emptying of the stomach and the duodenum. Complications seen with these, as I said, nausea, vomiting, pain, abdomen, and reflux are 23%, 19.9, and 14, and mortality is very, very low. Very rare to have a gastric perforation, an ulcer, or an obstruction. Early removal, the patient sometimes doesn't tolerate at all. So 3.5% out of 100 patients, or 3.5% of the patients may need an early removal. Non-balloon options, we have one standard therapy, which is also FDA approved aspiration therapy. Then other restrictive procedures of the various restrictive procedures, we have one called pose, and then the ESG, we all know it's almost becoming a standard of care. In aspiration therapy, in various studies, the excess weight loss has to be shown to the extent of 49%. What we do here is patient takes his meal, and after 20, we put a device, something like a endoscopic, per oral endoscopic gastrostomy tube is placed in the stomach, and the tube comes out of the anteroperitoneal wall, and after 30 minutes, or after 20 to 30 minutes of his taking meal, 30% of his, I think I will go back to this, because 30% of the fluid is aspirated out, and this is I must like to share with you all that this is a FDA approved treatment. So we can always go for this. I think we can go to the next now. Restrictive procedures, pose, where we use a device called incisionless operating platform, 55 millimeters in size, having 4 channels. A small thin endoscope goes through this, and the other 2 are used for grasping and putting anchors. So what we want to do is endoscopically pull the fundus of the stomach inside and try to create a stomach which looks like a sleeve post-sleeve gastrectomy. That's the procedure. I'm just giving an animated video. This is for G-leaks for grasping the antrum, and then you fire the anchors. So usually 10 or 12 anchors are good enough to create a stomach which looks like a sleeve gastrectomy. Endoscopic gastroplasty, where we use a device which is fitted to the tip of the endoscope. It had a curved needle here with a suture, something similar to Proline, and we try to suture the greater curvature and create a stomach, something like this, something like what we get in sleeve gastrectomy. So along the greater curvature, the stomach is sutured from 5 to 6 centimeters above the pylorus to obliterate the almost the whole of fundus of the stomach. So you can see here the suturing is being done here, and this is the post-sutured stomach. 30% excess weight loss at 6 months, and people have claimed up to 53% with this device, almost similar to what we get in sleeve gastrectomy. And this is the size of the stomach seen on contrast studies after this thing. Malabsorptive studies, I think I'm running short of time. I'm just 25 minutes, so another 3 minutes are there for me. Various types of Teflon sheets are there. a duodenojejunal about 65 centimeter, and a gastroduodenojejunal about 120 centimeter long sheet. The purpose of these, they can be introduced endoscopically. The purpose of these sheets are to prevent absorption, mixing the food or chyme which is going down with the bile and the pancreatic juice till it has passed the duodenum and the jejunum. The next is Revita DMR, which uses a balloon filled with hot water. The duodenal mucosa is lifted, and the mucosa can be now coagulated with a hot water balloon or with radiofrequency ablation. The latest in these techniques are the incisionless anastomotic systems. I'll just share a small video of the duodenojejunal sheath. You can see the food goes out and down, and beyond the jejunum only it mixes with the food. The mucosal resurfacing, you can see here, the scope has gone, and then the mucosa has been lifted, and now a balloon has been inflated, and this balloon with the hot water can always cook the surface mucosa of the duodenum. Usually 10 centimeter is done coagulated at a time. We have to be careful that whatever we do, it has to be below the ambulavator. Incisionless magnetic anastomosis is a very new thing, where two octagonal magnets are placed for doing a gastrogeniostomy or gastroantrostomy. And somehow they are so smart that they will attach to each other exactly at the same place where they have two. And you can see that octagonal ring here. One is being introduced with from above with a gastroscope, and the other is coming from below with the colonoscope. Transoral outlet reduction discussed. We have done a Roux-en-Y, and now there is a pouch dilatation, and also the anastomo treat as a regional surgery. You can always go in and use any of the endosuturing devices to make the outlet narrower and give best possible results. This is one of the endoscopic bariatric procedure for revisional therapy. You can suture, you can put clips to make the anastomotic narrower. Ladies and gentlemen, there are various indications, but we also have to know contraindications of endoscopic bariatric procedures. A patient who is not ready for this, he should not go into this. I have people with a 28-30 BMI who want the weight to be reduced for some purpose. Alcohol abuse is a relative contraindication. Psychiatric patient is the main thing which contraindication for me is lack of commitment to nutrition supplementation, and long-term follow-up is required in these cases. They're not ready, we should not take this. I would like to conclude here with a small statement. It is a new therapeutic option. Multiple devices are available, and multiple are also in the pipeline. It is comparatively safe. It must be used in conjunction with multidisciplinary program. Whatever we do, whatever research we do, our main purpose should be the complication rate must be less than 5% if you are doing any endoscopic bariatric innovative procedure, and at least we should be able to get 25% of excess weight loss reduction if we are doing. Otherwise, we should not be doing any endoscopic bariatric procedure. Thank you very much, Professor Sunil Kumar, for inviting, and thank you very much once again for making me a part of today's program. And thanks.
Thank you, Dr. Khanna. It was an excellent lecture. We've almost covered up within 25 minutes all the aspects of endoluminal bariatric surgery. From his lecture, we could come to know how we are going ahead in endoluminal endoscopic surgeries. And in future, we'll see more of this from Dr. Khanna as well as from various centers all across India. Thank you very much. I don't see any questions. Anurima might be knowing.
Yes, sir. On the YouTube channel, we are having questions from the delegates. And since his talk was so illustrative that I don't think academically any question is there, but there is two repetitive question that can we join your center for training in endoscopic bariatric surgery?
Why not? Why not? Yeah, anyone who wishes to come, they are most welcome. They can get a hands-on also exposure with me on ERCP, on spyglass cholangioscopy, on endoscopic balloons. But you have to let me know in advance so that I can pull up the cases for you. Those who want to join, if they want to go come for ERCP also, that time I'll be demonstrating that. So mail me. I will keep you booked. We have 25 surgeons undergoing ERCP training. They will be joining us on hands-on program. We are keeping 20 cases for them, and that time you can always join as an observer with them, so that you are exposed to various types of therapeutic endoscopy.
Thank you, sir. That was very useful. I think that answers a lot of questions that have been coming and the concept of this whole program. And just before we move ahead, I just want to clarify that we are not changing the order of the presentations. So Dr. Subhash Khanna had some engagement, so I had just exchanged this session with him. I would be speaking at the end, so the rest of the session continues as it is. Thank you very much,
I'll
sir.
stay with you for some time, another 15-20 minutes for the next talk. I will, and thereafter I might be leaving with apologies because I may have to leave.
Thanks, Subhash. It was an excellent talk. Excellent talk.
Thank you. Thank
Even in this COVID era, I find you immaculately dressed like a British surgeon. Blue jacket and blue tie.
Thanks very much. So I will be putting on my mask now.
Thank you.
Thanks.
Back to Arunima.
Yes, Satvir, we can go ahead with the next talk by Professor Sunil Popat.
Thank you, sir. Our next speaker is Dr. Sunil Popat, sir, and he will be talking upon endoscopic management of upper GI bleed. And our honorable chairpersons will be Dr. P.P. Chawla, sir, and Dr. Satish Mehta, sir.
Good morning. Am I audible? Am I audible?
Yes, sir.
Good morning, sir. I'm audible, sir. I have great pleasure in introducing Dr. Popat. He is the president of the society and is the director of Nidhi Hospital, Ahmedabad. He has got more than 20 years of experience in this sort of endoscopic surgery, and he is attached to various hospitals, and he has been training people. He's a versatile person, excellent speaker, and I have great pleasure in presenting Dr. Popat to you, ladies and gentlemen.
Thank you, sir. Thank you for the kind words. Am I audible, Sunil?
Okay.
Good
afternoon, Dr. Popat. Please proceed.
Yeah, Satish, how are you?
Fine.
Can you see my screen?
We can see, we can hear you.
Okay. So thank you very much, ASI Jharkhand chapter, for this wonderful program and inviting me. As president of IAGS, I'm very happy to see that endoscopy training are being percolating into other association also, and in our mother association, ASI also getting up and taking up these endoscopic courses. I bring greetings from Ahmedabad. My topic has been the management of upper GI bleeding. It's a very vast topic, so I will concentrate on some of the aspects which are very common. Basically, upper GI bleeding nowadays, most of the patients presenting with upper GI bleeding is because of the causes related to portal hypertension, such as esophageal variceal bleeding, gastric variceal bleeding, or bleeding from a gave. Sometimes we get bleeding from malarious or duodenal ulcer or severe erosive gastritis. Very rarely we get dulafoy's lesion or vascular malformation. Most of these patients present as hematemesis. Some of them will present as melena, as you are aware. First and foremost thing important is stabilize the patient. If the patient is in shock, admit the patient, give initial treatment, stabilize the patient, and arrange for emergency endoscopy. However, if the patient's hemoglobin is less than 7, then you may not see some of the lesions. So stabilize the patient and then proceed for endoscopy for GI bleeding. So you do initial assessment, resuscitation, pre-endoscopic management like we all do in hospitals. Then when we do upper GI endoscopy, if there is active upper GI bleeding, we do endoscopic hemostasis. If it is not possible, then we have to resort to other options. If there is no bleeding at all and there is very low risk of further bleeding, then we continue with the medical treatment. If there is no source found of the upper GI bleeding, then consider doing colonoscopy and other investigations. First and foremost thing is you need to have a good endoscopy chute available to you for this kind of therapeutic upper GI endoscopy. You need to have therapeutic upper GI scope. You should have variceal bands, band ligators available in few sets. You should have a cyanoacrylate glue in several ampoules available. It is available as 0.5 ml and 1 ml ampoules. You should have various sclerotherapy needles like number 21 for glue injection, number 23 for sclerosant injection. Nowadays, the sclerotherapy for esophageal varices is not routinely practiced. Most of these esophageal varices are taken care by the bendings because it gives wonderful result and less complications. You should have endoclips or endoloop available in your endoscopy chute, and most importantly, your endoscopy assistant should be trained for the management of GI bleeding, because it is not only the one person's job. You should have trained assistants who should know
glass
what to do.
डेट डाल देते हैं चावल भी पड़ा है हमारे पास
Position of the patient is very important. Left lateral position is very comfortable for the patient and also for the endoscopy surgeon. Preferably, you should have anesthetist by the side. If you are working in a very remote area where you don't have anesthetist, then one of your staff should be trained to take care of the patient, because some of these patients may have profuse bleeding or blood clots in the stomach, and they may aspirate while you are doing the procedure. So it is very important to take care of the patient, and preferably do under conscious sedation, propofol, etc., so that the patient is stable and not retching all the time. Because if you are doing esophageal variceal bending or a glue variceal injection, and if the patient is retching continuously, you may end up doing more bleeding rather than helping the patients. So esophageal variceal bending helps us in taking control of the bleeding and also in the ablation of the varices. And it is indicated for the treatment of primary esophageal varices, recurrent esophageal varices. Many patients would require 2 to 3 bending sessions to completely ablate the esophageal varices. These things needs to be explained to the patient and patient's relatives before doing the endoscopy, because sometimes patient and his relatives are under the impression that it is only the one endoscopy session and that's it, and after that there will be no further varices to be taken care of. Now this is a picture of a large esophageal varices. As you can see, multiple columns. And here I am showing a short video. Before I start the video, I'm just showing that this is a band device applied at the tip of the endoscope, and through that cap you are seeing the varices. This is second or third session of the bending in this particular patient, so that you will see some band ulcers also. What is important is this band device should be applied properly at the tip of the endoscope. It should be applied in such a way so that the first band here will be as near to the tip of the scope as possible, and your suction machine should be working properly. Otherwise, you may not be able to suck this varix inside the band cap. So here you can see this is the band ulcer from the previous bending. Now it is very important that this kind of complete suction of the varix inside the band cap has to be done, and it should be inside the band cap when you apply the band, so that the band applies properly. Most of the bending devices are now available with 6 bends, and majority of the endoscopies, almost all of them are using 6 bends per session as a standard protocol. However, you can utilize more than 6 bends, even 12 bends if there are large varices, but it is not advisable because it causes some chest pain post-procedure. And if you apply more bends, there will be more chest pain and chances of more retching, which can lead to further bleeding. So it's preferable to use 6 bends. Post-procedure chest pain and dysphagia is one of the short-term complication. Sometimes it can cause esophageal obstruction, but it's very, very rare. Band ulceration is quite common, but it's not harmful, and it is treated medically with proton pump inhibitors and other supportive treatment and sucralfate. Sometimes you may end up having a bleeding after doing the bleeding, after having the bending done. And what you need to do is you need to go back inside, look where the bleeding is coming from. It is from the slipped band from the varix, and you can apply another band, or you can inject that particular varix with the glue or sclerosant. Infection is very, very rare. I have not seen in last 30 years of my endoscopy practice. Aspiration is quite possible, and that is why it is preferable to have anesthetist while you are doing such a therapeutic procedure. Then we come to the gastric variceal glue injection. So for gastric, duodenal, or rectal varices, you can use a cyanoacrylate glue. Again, stabilize the patient, and these patients are stabilized by IV fluid, the PCVs, and other medicines. Also, we are using terlipressin for portal hypertension patients, and sometimes also use somatostatin. Now, a procedure should be done under conscious sedation, as I said. Staff should be prepared. You need extra precautions for glue injection, such as the glasses. The staff should wear glasses. Even the patient should be wearing glasses so that the glue doesn't go inside the eyes. The staff should be trained, and you should have acetone available in your endoscopy theater, because sometimes this glue can block your endoscopy channel, and it is a routine practice for us to flush the endoscope channel immediately after the glue injection with acetone. So you should have acetone available. First, you do proper diagnostic upper GI scopy. You look at the fundal varices, the gastric varices. You plan the variceal injection, that in which position you will be able to do proper injection. Then aspirate the blood from the stomach or clots, whichever in the stomach. Target the varix, decide the scope position, decide the endoscopist position. If you are doing a second or third injection, palpate the varix first with a blunt tip instrument to identify where is the varix which is obliterated and where is the varix which needs to be injected again. The glue needle we are using is 21G. Always prepare the needle, flush the needle with saline or distilled water. Check in and out movement, injection. Then check the varix, scope and needle position, precise entry into the varix. I'll describe the procedure once I'm showing you the video. And we may do multiple injections if needed. We need to prevent the glue spillage inside and outside the scope. However, it is not 100% preventable. Sometimes you may come across spillage, and I'll show one video of that also. So here is a patient with gastric fundal varices, you can see, and I'll show you the procedure, how we are doing it. So this is a J maneuver. We have already located the varix. The needle has come out, and we try to enter the varix at 90 degree or perpendicular. Go the needle inside the varix, inside the lumen, and then inject 1 ml of glue, followed by 1 ml of, followed by 2 ml of distilled water. 1 ml of distilled water, followed by 2 ml of saline, 1 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 ml of saline, There is another injection in the nearby varix. So with intravaricial glue injection, the varix immediately obliterates. The varix immediately obliterates, and you will see, you can feel it, a very hard substance when you palpate it with your sheath of the needle. So as you can see here, there is no spillage of glue outside the varix, inside the lumen of the stomach. For second injection, we have changed the needle. So make sure for every injection, you are using a new needle and not using the same needle. Now this is another video. Here I will show that sometimes we can see the bleeding coming out as soon as we withdraw the needle after the glue injection. And the trick here is to inject again in the same varix. So here you can see the esophageal varices as we travel down to the G junction and we enter the stomach. So narrowband imaging can identify all the varices. As soon as we are inside, you can see. Now here is the varicial injection, as you can see, the varicial bleeding. And so we need to inject again from the same bleeding point. And one injection was done, and from that needle point, patient was bleeding again at the same time while we were doing the procedure. And so we do another injection of 1 ml glue through the same hole and obliterate the varix, and the bleeding is stopped. So it is of utmost importance that we know what to do once we have the bleeding from the post-injection varix. Here in this case, again, you see a lot of varices here, and I'm going to show you how the glue can spill inside the stomach cavity outside the varix. So here we are doing the variceal glue action. And as you can see, some of the glue is seeping out. Make sure it doesn't come onto the endoscope tip. Another injection is done. And as you can see, we could obliterate the varix without having the glue on the screen. So it is of utmost importance that you keep your scope, your patient safe while doing this procedure. Another patient with a portal hypertension, severe repeated bleedings, presented with severe bleeding from the duodenal varices. As you can see, we are in the second part of duodenum, just near the ampulla, large multiple varices with an ulcer on the one of the varix. That was the bleeding point. The bleeding has stopped with terlipressin and primary treatment. Within few hours, we are going in and injecting the varix with the cyanoacrylate glue. Again, the injection is intravaricial, as you can see. After the injection, we wait for 15 to 20 seconds for it to obliterate before withdrawing the needle out. And this is another varix which is still patent, so the injection is done. The same patient is having the gastric varices also, fundal varices. So we do a fundal variceal glue injection also in the same patient. The most common complication of the glue injection in fundal varices is the gastric variceal bleeding, and one has to be careful to avoid it, and if it happens, to identify during the procedure and take care of it. Pulmonary embolism is a rare complication. We haven't seen it in the last 30 years, but it can occur. It can occur if large amount of glue is injected with lot of pressure into a small varix. Our protocol is to inject 1 ml of glue and 2 ml of distilled water or saline in one varix. And at a time, we inject not more than 4 varices. So not more than 4 ml of glue in total in one session. However, I have seen people injecting more than 10 ml also, but then you are inviting the trouble. The trick here is to inject 2, 3, or up to 4 varices at a time with 1 ml, obliterate those varices, go back in again after a month, and if you find any unobliterated varices, you can inject it again. So in nutshell, I can show you that if you have endoscopy available in a GI bleeding patient, then you do upper GI endoscopy after stabilizing the patient. If there is esophageal variceal bleeding, do variceal band ligation, control the bleeding, and eradicate the varices. Very rarely it is not possible to control the bleeding. In such case, you may have to use a glue injection. Nowadays, we don't use balloon tamponade. We almost 100% we control the bleeding endoscopically. And if it is too much of bleeding, then very rarely you may require tips. Similarly, we can use the somatostatin glycine octreotide and restrict variceal bleeding, glue injection, and control the bleeding. Now I move over to duodenal ulcer bleeding. The duodenal ulcer bleeding has reduced in incidence significantly with the advent of proton pump inhibitors. And nowadays we are seeing very few of the patients having duodenal ulcer bleeding. The modalities we have to control the bleeding, first and foremost, is the PPI injections. Second thing is a injection of a sclerosant. We use a diluted adrenaline, which we call epinephrine injection here to control the bleeding. And we can also use a coag grasper to coagulate, or we can use a clip to apply over the visible vessel and control the bleeding. So here is a short video of a bleeding from a base of the duodenal ulcer, and injections, diluted epinephrine injection. Majority of the patients, you can control the bleeding. Sometimes we may have to use clip, like nicely shown in this video. There is a visible vessel bleeding in the second part of duodenum, which is quite unusual. One has to learn how to open and close and apply the clip, the endoscopic clip, because sometimes it is tricky. If you don't know it properly, you may waste the clip. So even after application of one clip, the bleeding is not controlled. So another clip is applied. And after 3 clips, the bleeding is completely controlled. Very rarely you can have a duodenal perforation, and you make, if it's an iatrogenic perforation, you can close it with an UGIscope clip if you identify it early. This is a video I collected from one of the colleagues who is showing that UGIscope clip used on the bleeding ulcer in duodenum. We don't routinely use UGIscope clip for bleeding duodenal ulcer, but it's one of the modality. You can see bleeding is completely controlled. So then I come to the Mallory-Weiss stare. Most of the Mallory-Weiss stare bleeding is stopped by the time we go in with the endoscope. Once you stabilize the patient and you go inside with the endoscope, most of this Mallory-Weiss stare, the bleeding has stopped. Very rarely you see the bleeding, and you can control that bleeding with injection of epinephrine, or rarely have seen people using glue, but there is no major vessel to obliterate. So epinephrine injection is fine enough. Here I am showing a video from my colleague who is using UGIscope clip for Mallory-Weiss stare bleeding. But as you can see, the bleeding has stopped by the time the endoscopy is being done. And the ovoscope clip is being applied. Most of this Mallory stair bleeding can be controlled medically, and the endoscopy is required just to check that the bleeding has stopped. One of the important modalities, argon plasma coagulator or APC, is most commonly used in GAVE or gastric antral vascular ectasia, which we see in many patients of portal hypertension. And because it is expensive, APC is not available everywhere, but it has a very good principle. It does surface coagulation using the argon plasma, and it has various application probe with different tips. You can coagulate at the tip or on the lateral aspect like ERCP scope, or radially all across. And the probes are available in various sizes. And it is really useful in GAVE bleeding, also in radiation gastritis and radiation colitis. To conclude, ladies and gentlemen, upper GI bleeding nowadays, in majority of the cases, is controllable with the endoscopic endotherapy, what we are doing. And it is of utmost importance for the surgeon endoscopists to learn how to control upper GI bleeding. Thank you very much for your patient listening.
Dr. Popat, it was an excellent and lucid presentation. I must really congratulate you for the lovely talk. It was
Thank you, sir. Thank you.
Full with beautiful slides, beautiful videos. Thank you very much.
Thank you.
Thanks, Dr. Sunil Popat, for
Yes, sir.
lovely exposition on the whole subject. I know that it's a very vast subject in itself, so each subtopic requires a presentation. But for the beginners, you have completed the whole topic in a very nice way. And I think this is also very important because when we start endoscopy, we are going to encounter GI bleed. This is very common presentation which we all physicians, surgeons come across. So slowly, besides diagnosing, we have to master the techniques of controlling these bleeding, and especially varices and non-ulcer bleeding. All these things we have to learn slowly and bring ourselves to that level. And also we have to enrich our armamentarium with the accessories and the good diathermy and other materials which are required to do these procedures. Thank you very much.
Thank you, Satish. Thank you very much. Thank you, Sunil Kumar and Arunima.
Sir, there is one question. There were a lot of questions on upper GI bleed, but most of them you have answered in your talk, like what are the modalities of doing it and what are the things that you use for it. One question, which is an important one, is that how do
Can't listen to you.
I think her voice has dropped,
Yeah.
maybe some network problem.
Okay, before she comes with the question, it was excellent talk, Sunil.
Thank you.
But my one question on behalf of everybody, what is your end point in a variceal endoscopic variceal treatment? Suppose you have got a grade 3 or grade 4 esophageal varix and with history of bleed, and you are doing a band ligation. So you need to do frequent banding. So what is your end point?
Yeah, excellent question, Sunil. So first and foremost is we are doing an esophageal variceal banding to control the hemorrhage and then to ablate all the esophageal varices. So if we have 3rd degree, 4th degree, multiple column esophageal varices, I would do first session as soon as it is possible after the patient has arrived. I will check again after 2 to 3 weeks, depending on patient's condition. And that endoscopy, the second session will do variceal bending. And then we'll do 3rd session, maybe after 3 to 4 weeks, and see that all the varices are obliterated. So endpoint is obliteration of all the esophageal varices. Once they are obliterated, then we'll put the patient on regular screening upper GI endoscopy. So initially for first 3 months, we'll do endoscopy and then yearly. And as soon as the varices come back, we'll obliterate them. And the same thing applies
Very
for
nice.
fundal varices. So fundal varices, if you are doing an upper GI endoscopy in a portal hypertension case and the patient is bleeding from esophageal varices, you have taken care of esophageal varices, but the patient also has gastric fundal varices, then we cannot leave them as it is and wait for them to bleed. We need to obliterate the fundal varices also to prevent future bleeding. So any patient with esophageal and fundal varices, we need to obliterate all the varices. Previously, when we were doing the esophageal variceal sclerotherapy, the dictum was not to do sclerotherapy in the second degree esophageal varices when they have not bled. But now with the advent of this banding, it is a very complication free, very smooth procedure. And unless it is a grade 1 varices, which you cannot actually bend, grade 2, grade 3, grade 4, all these varices, we can bend them and we can obliterate. And even the gastric fundal varices, which have not bled yet, we would obliterate them to prevent future bleeding.
Yeah, is Arunima back or is still our internet is not? It was a wonderful talk, Sunil.
Thank you. Thank you very much.
Sorry, my internet got disconnected.
Yeah. No problem.
Yeah.
Dr. Sunil Popat has already answered the questions.
Yes, I followed it on the YouTube.
And it is always a pleasure for Dr. Sunil Popat, my Hamna, my friend, and plus IIG's president to be here. Thanks, Sunil, to be here. If you have got little time, you can stay. You know, it's the last talk. Govind Raj, our real star. So back to Arunima and Satvir, please.
Hi, Govind Raj.
Hi, Sunil.
Hello, Govind.
Hi.
Hello,
Yes,
Govind.
Satvir.
Hi, Satish. Hi, Satish.
Hello.
Hi, Sunil.
Nice seeing you.
Thank you, sir. To move on to our next topic by Dr. Govind Raj, sir. Sir will be talking upon therapeutic ERCP, and our respected chairpersons will be Dr. Sanjay Kumar from Tata Motors and Dr. Arunima ma'am.
Thank you, Satvir.
Sanjay Kumar is joined from Tata Motors. I think it's Sanjay Kumar from Daltonganj and Arunima possibly.
Sir,
So-
from Daltonganj, sir, he is not available at this moment.
Who?
Dr. Sanjay Kumar, sir, from Daltonganj.
Okay. So Arunima will take it. Okay.
Yes.
Yeah, I think I'm actually very happy to chair this session on therapeutic ERCP because this is one of the things even I have been doing for the last more than 7 to 8 years. And I think it is one of the most advanced endoscopic procedures. And gaining mastery at this would be, I think, any endoscopist would be wanting to do this. So just introducing Dr. K. Govind Raj. He has got multiple affiliations to his name, like he's the Vice President of South Zone of IAGES, and he is academician. He obtained his diploma in laparoscopy from Professor Stellar Klenenhuis, Germany, and diploma in minimal invasive surgery from European Institute of Telesurgery, France, and is trained in AMC Amsterdam for therapeutic endoscopy. And he has a special interest in endoscopy because he has been the organizing chairman for EFIAGS 2017 in Trichy, mid-IAGS 2017, and the first international conference for IAGS in Colombo. He has also been the chairman for FIAGS 2018 in Trichy and organizing secretary of FAGIE 2019 in Trichy. So I think without wasting any more time, we would be hearing his talk on therapeutic ERCP. So all yours.
And I would like to add that sir was my teacher, and because of him, I am doing endoscopy in Jharkhand. And recently, I finished 101 cases, sir, of endoscopy and colonoscopy in Jharkhand. All because your teachings. Thank you, sir.
Thank you, Arunima, for that wonderful introduction. And thank you, Satvir, for the best compliment to get from a person whom I have taught.
And first of all, I should congratulate the Jharkhand Society for this wonderful meeting. And thanks, Sunil, for organizing and inviting me. I'm so happy to be in this platform where my mentor and my guru and all should name him as the father of endoscopy for India, where Professor Krishna Rao is there. As Satvir said, all I have learned and what I'm doing today is because of Professor Krishna Rao. And to start with, I've got all the stalwarts in the field of therapeutic endoscopy today in this platform, right from Subhash Khanna, Sunil Poppet, Satish Midda, and all of them are there. And to start with about the therapeutic endoscopy, what is ERCP? Because ERCP has been there for almost 40, 50 years. As Professor Krishna used to say, there were a lot of comments when he started ERCP in the way back in late 1960s. And so as a surgeon, we have started doing ERCP, which is known as the endoscopic retrograde cholangiopancreatography. Basically, it was started to use basically to tackle the CBD stones. And now it has the entire gamut of what all we do in ERCP is almost infinity. And it's a technique that uses both as luminal endoscopy and with the imaging using the fluoroscopic imaging. What we combine is now is using an ERCP. And basically you do an ERCP using a side viewing scope. And what are all the investigation which adjunct ERCP are? The older techniques are like ultrasound abdomen, the MRCP, the helical CT, then endoscopic ultrasound, which is very, very useful, particularly when you're doing tackling the stones, intraductal ultrasonogram, which is really high funda, and laparoscopic intraoperative ultrasonography and intraoperative cholangiography. These are the few investigations which really add to your ERCP. And MRCP, I would say, is superior to ultrasound and CT, particularly in both benign and malignant lesions of the hepatobiliary system. And modality of choice for the option of characterization of causative lesion is, I would say, is if you have an EUS scores over MRCP, particularly when you have flat stones where MRCP also misses, and the percentage of positivity of flat stones which can be picked up in endo ultrasound is almost 99%. And the timing and technique of ERCP technique is, there are cannulations, two techniques are there, which is a wire guided, which is a 2-wire guided or single wire guided. Sphincterotomy can be done either using a needle knife or using a sphincterotome, and stone extraction can be done using a balloon basket. And the last one, which I'll be talking about, is the laser, because that comes as a separate technique in spyglass. And indications for ERCP in a pre-op: raised LFT, intrahepatic biliary duct dilatation, imaging documentation of stones, particularly cholangitis, which are responsive to treatment, gallstone pancreatitis, unsuccessful prior duct clearance, and emergency ERCP, particularly when there is severe cholangitis, which is refractory to treatment. And preoperative ERCP, what are the advantages? 1, shorter time of surgery, no need for intraoperative cholangiography. 2, the real cons, I would not say, because it is very little. It depends on surgeon to surgeon. Separation of services, because you do an ERCP prior to an you do an lab chori in case of a stone, and then that will be called a separation of services. But in centers where the same surgeon does the ERCP and the lab chori, we can do it in the same sitting. Only disadvantage is, I would say, if you do a procedure which is very long, a lot of air will be instilled inside, gas will be there, it will become very difficult for a lab choli to be done at a year. So in our center, we have a less than half an hour of ERCP. Put both sides, you need to have a Riles tube to let out the air and a flattest tube to let out the air. Wait for half an hour and do the procedure immediately. You can do a lab choli, very easy. We have presented this paper in various articles and journals also regarding single stage ERCP and lab choli. Intraoperative ERCP, it's the same like an the pre-operative ERCP. Only the difficulty is you intubate the patient, and the difficulty, as I said, only the positioning will be very difficult. And sometimes there have been instances where I have been called into when a lab choli is being done by assistant. They have very difficult time in identifying a CBD stone or identifying an migrated CBD. They have done an intraoperative spyglass also. So these are the few techniques in which we use the transoral route. The advantage is the pros are no additional burden on anesthesia. The only difficulty is the positioning, and as I said, the gaseous distension of the bowel. Post-operative ERCP is
whenever you have a positive intraoperative cholangiogram and the CBD stone symptoms are there after a lap chole, abnormal incision, particularly there is jaundice after a lap chole, and failure to retrieve stones which are in the CBD, you have an post-operative ERCP. These are the kind. And of course, challenging stones. Challenging stones are when the stones are bigger than 1.5 centimeter size, and the stones are difficult to capture in a basket, and stones are associated with biliary stricture where you have proximal stone, and stones in the patient with the GALX and an altered GA anatomy where a Roux-en-Y bypass or Billrod 2 has been done earlier. I'm going to show now a few variety of cases which will present to you and which we have done and how we are tackled. And this is a 40-year-old male who presented to us from a peripheral hospital peritonitis. He was evaluated and the resuscitation was done by the initial surgeon. Laparotomy was done, drained 1 liter, or he had drained 1 liter of bilious fluid. And the gallbladder momentum was found to be adhered, found a complex mass there, and perforation site could not be made out. So what he did is for thorough lavage, he closed with a drain. That's the best thing a surgeon can do in a peripheral center. Post-operative, the patient recovered, but the drain was almost perforated with 800 ml every day. He was referred to our hospital for an ERCP. On admission, the patient was very stable and he had a copious biliary drainage, and we subjected him to ERCP. ERCP could not be done in the, we could initial ERCP, when you did a side viewing scope, we couldn't identify the ampulla at all. And at a verge of the termination procedure, we noted near the pylorus using a side viewing scope. From the side viewing scope, I changed over to end viewing scope, regular upper GA scope, and there was a ampulla like opening there at the duodenal end orifice, and which was there abutting with the stone. I pushed the stone and removed the stone, cannulated it, and it was a fistulous plaque into the CBD. What had happened is there was a stone that was obstructing in the distal CBD, causing a fistulous opening into the proximal part of the duodenum at the junction of the gastro-duodenal junction. And so I placed in the stent, and the second day, the patient drainage came down, and the patient was discharged and asked to come for an MRCP. And this is the video which I'm showing, and you can see on the left video, that is an anomalous opening there, which I'm seeing on the proximal part of the duodenum. I can see there. See, this is the proximal part of the duodenum. We can see the normal anomalous opening there. And here, after I've inflated, I've injected the dye in the lowermost portion, it is entering into the CBD. What I'm doing here is I'm using an end viewing scope here, and I'm cannulating it. See, I'm cannulating it. I'm putting in a guide wire there. And what I did is I pushed in the stone, I'm cannulating it. After that, injecting the dye was going into the CBD. So it is nothing but a fistulous plaque, which is very, very rare to have a stone. I put in a stent there. And this patient then went home. Yeah, we lost follow-up the patient. 1 year later, the patient presented with obstructive jaundice. He came back again. I did an ERCP. The blocked stent was removed. I placed another stent, advised ERCP. Again, the patient didn't undergo an ERCP, went away. Because this MRCP was advised because I wanted a documentation of the distal hepatobiliary tree. That is the distal CBD. What is the reason we couldn't identify the ampulla in the position? And second scenario is a 25-year-old female, a calculus cholesterol lap chole done. Drainage tube kept in the gallbladder bed, 500 minimal bilious drainage was there for almost 3 weeks, referred for an ERCP. See, this is a post-lap chole bile leak. So therapeutic ERCP not only deals with the stone, but also with the post-lap chole bile leak. You can see there on the left image, there is a nice leak there. You can see the clip there. And one thing, nothing much to be done about it. You put in a stent here. See, what I have done is I put in 2 stents here. 2 stents are placed there, and the bile leak reduced within a matter of a day, and the patient was discharged, but I didn't remove the DT there. The DT was kept for a minimum of 1 week, removed after 1 week, and the patient went home fine. And this is the third case, is a post-open chole with the T-tube referred for an ERCP. It is complete disruption of the common hepatic duct. You can see here, I'm doing an ERCP there. There is a T-tube which is kept there. And as I injected the dye into the proximal part of the distal part of the CBD, you can see their complete disruption. You can see the lower portion of the CBD there, and this is the biliary tree on the left side. The biliary tree is there, and the lower portion is here. Complete disruption. Nothing can be done about it. The patient was advised to undergo a biliary open or a laparoscopic procedure. He was asked to wait for 6 to 8 weeks. Then he underwent a hepatico-jejunostomy. And this is another case in a scenario of where the post-lap chole referred with obstructive jaundice. The ultrasound showed a dilated intrahepatic biliary tree. There was a distal CBD which was not visualized, and ERCP was done. This is another interesting case. I am doing a sphincterotomy there. On the right image, if you see, I put in a guide wire there. There is a complete cutoff there. What had happened is the CBD was cut off, and they have done a nice tying of the CBD was done. I'm trying to poke the CBD there. You see there in the right image, I'm not able to enter there, go the plastic guide wire beyond that portion. So it is a complete cutoff. Nothing much can be done on an ERCP for this. So patient need to undergo a definitive procedure. It's a surgical procedure. So these are the cases where still, even in this such advanced era of therapeutic endoscopy, you have limitations for therapeutic endoscopy here. And another interesting case is a CBD calculus with gallstones disease, obstructive jaundice, ERCP sphincterotomy, Dormia basket was attempted. The stone got stuck in the basket, and I couldn't remove the basket. So this is the one reason where I still remember Professor Krishnarao used to say, Sohenda literature, it is like a life-saving procedure when you have a stone stuck in a ERCP basket. So this is what then. There were a lot of suggestions to me. A lithotripsy can be cut using a basket. The cuts a basket can be used, and the basket in the CBD stone in it was in the tail of the duodenum. So I didn't know what to do. I did a CBD stenting. The patient was discharged and asked to come back about 1 week. Then there are 2 or 3 options left for me: a laparoscopic CBD exploration, open CBD exploration, and ESWL. ESWL was suggested by Professor Krishnarao. We did an ESWL. The stone was which was stuck with a basket in the CBD was broken with an ESWL, and the basket was able to be removed after 2 weeks very easily. And see, you can see the image here. Yeah, this is a video which I'm playing here. I'm trying to cannulate here. At the end of this video, after I make a cut and after I remove there, you can see there how the stone was stuck in the CBD and we're not able to remove the basket. You can see the basket there lying there in the duodenum there. So what I did was in that first position, I put in a plastic stent, came out. I had to breathing time to think over, ask my colleagues. That's what I would used to say. Never think that you are the top boss always. There is always a top boss there better than you. You ask your colleagues what can be done about it. I sent the patient home. I explained to the patient this is what has happened, and I got the real confidence of the patient. Patient came back to me, did ESWL, the patient went home fine. So this is one of the very difficult cases which we were lucky that the ESWL was available. Retrograde ERCP is very interesting. You don't get it every day. 30-year-old gentleman who was referred to our center for an ERCP for CBD stone. He had undergone an open cholecystectomy with a bile leak through the T-tube. He had previously undergone a GJ for GU, and the patient was investigated posterior for an ERCP. During ERCP, we found that the deformed pylorus was there. I couldn't enter into the second part of the duodenum through the regular route. So I had to use a longer scope. I have a double lumen scope also. I have got an enteroscope. I used an enteroscope here, and then so you can see here I'm entering the stomach there, but I was not able to enter into the proximal part of the duodenums here. Here the duodenums there. So I'm entering through the GJ. I'm entering into the retrograde route. When you are going through the retrograde route, you may not use a side viewing scope. You can use a regular upper GI end viewing scope. Here, see, you see the ampulla here in the retrograde route. It is a regular upper GI scope. Only thing is because a long route, I had to use an enteroscope here. I used an enteroscope. A regular method of cannulation was done. After the cannulation was done, then I injected and I found the stone. I removed the stone and then put in a stent and came out. So it is a routine procedure, but it is a different route because you are going in a retrograde route. It was done. So, and a post-open chole retained CBD stone, 60-year-old lady presented with obstructive jaundice. Open chole done 30 years back. Ultrasound showed medium-sized stones in CBD. Patient was taken off ERCP. See, I'm showing this video because this is a nice case of a huge papilla where you will not be able to cannulate using a sphincterotome. So what I do was a needle papillotome. This is how I do a needle papillotome. Once you do the nice needle papillotomy, the stone just slips out of this huge papilla there. And this is similar way, another video here I'm showing. This is another huge ampulla there where a needle papillotomy is being done, and you can see the stone that can be visualized once I cut using a needle papillotomy. What I have seen is not many medical gastroenterologists use a needle papillotomy. Most of the surgeons are very confident in using a needle papillotomy. And within 2 seconds now, you'll see the stone abutting into the duodenum. You can see a nice stone there. And once the stone is seen, and it becomes so easy. You can see there in the huge stone there. I'm using another papillotomy needle sphincterotomy there. I'm just pushing the stone into the CBD, and then the rest of the story is the same one. And ERCP cholangiocarcinoma, as you all know, when there's a cholangiocarcinoma, if you're not planning for a definitive procedure, do the metallic stenting here. Here, there's a cholangiocarcinoma Klatskin tumor. I've done a metallic stenting. This is how a metal stent is there. There are two types of metal stents here, whether it's a covered stent or it can be an uncovered stent. Here I'm putting an uncovered stent. Usually I do an uncovered stent for this kind of a procedure. So what happens is the stent gets blocked. So see here, the stent gets blocked. The patient lived for 1 year. Stent gets blocked. What I'm doing here, I'm passing a plastic stent into a metal stent here. This is what I do. The patient was relieved of the obstructive jaundice, which has caused because of the tumor ingrowth, and patient lived for another 6 months and then died. It's a Klatskin tumor. You can do selective left and right hepatic cannulation here. On the left image, I'm doing a left hepatic cannulation. On the right side, I'm doing a right hepatic cannulation. And finally, you put in 2 stents here. The stents can be adjacent or it can be a OCD stent where you have a large clear display stent. Stent will be into the stent. So 2 stents will be there. This is one of the cases where we do 2 stenting there, right stent and left stent. And next, I want to show you a very interesting case. It's a periampullary growth, how it looks like. Periampullary, this is a periampullary growth. I'm doing a needle papillotomy. I cut open the ampulla into 2 like you cut an apple, then take multiple biopsies before you put in a stent here. Here, I'm doing multiple biopsies. Usually, I try to put in a plastic stent. And if the patient is willing for a definitive procedure like Whipples, we go for a Whipples. If the patient is not willing for a procedure or is not fit for a procedure, then I change this plastic stent into a metal stent at a later date. Here, I put in a plastic stent here. Okay. And next is an extracorporeal lithotripsy, as I said, has definitely changed the role of a pancreatic stent. And these are the few cases where you have a failed ERCP. Periampullary edema, you cannot do. All these cases, what I do is leave the procedure, terminate the procedure, wait for 3 days, go in again. It will be so easy to do a procedure the second time. Cholangiocarcinoma, sometimes you cannot do a procedure, you cannot complete the ERCP. Post-operative CBD strictures, it becomes very difficult to complete the ERCP. Morbid obesity, because positioning of the patient is very difficult. Poor general condition, definitely ERCP cannot be done. In a failed ERCP, definitely there's a role for PTBD. And there have been occasions where a PTBD has been done and railroading has been done, and through which the railroad technique we have done and retrograde ERCP also. And this is a very interesting case. 60-year-old lady presented with history of obstructive jaundice. For 1.5 months, patient investigated outside and diagnosed to have a cholangiocarcinoma. Patient was taken for ERCP, and then patient preferred to have a PTBD done. And the evolution of, now I want to talk about cholangioscope. I'm coming into a very, very latest and modern era where you're talking about cholangioscopes. It's all started with the mother baby scope some 20 years back. Only thing it is didn't get into the market because it is very fragile. I have seen people use a mother baby scope, break the scope in the first instance. So this mother baby scope now has become a spyglass or a DS-scope. This is how a spyglass scope looks like. It is from a company called Boston Scientific. And these are the few indications where virtual and optic chromoendoscopy, confocal laser endomicroscopy, and precise mapping for and delineation of intrarectal tumor. This is very useful. Particularly, I've seen it being used in particular in Japan extensively, where they do precise marking of the intrabiliary tree, take multiple biopsies, complete marking done, then they resect that area which is marked positive for a tumor. And these are the therapeutic benefits of an ERCP and spyglass. In pregnancy, fluoroscopy can be avoided. We have got 2 cases where ERCP cannot be done in a pregnancy. Patient came with cholangitis without an imaging, that is an C-arm. We have done using a spyglass, and the patient went home fine. We have done a stenting, removed the huge stone. Large CBD stones where ARCP could not be done, laser lithotripsy is done. Impacted stones in the intrahepatic biliary tree, migrated stents into the proximal biliary tree, endoscopic nasobiliary drainage, selective, and particularly for a spy bite biopsy, you do biopsy under direct visualization. So now the scenario is, for any Klatskin tumor, you can have a definite tissue diagnosis in 95% of the cases. And of course, intraoperative cholangioscopy has been done. I'll show a few cases. His first case scenario, 60-year-old lady who has had a laparoscopy, converted to open cholecystectomy, done 4 months back at a peripheral center. Intraoperative finding is necrosed gallbladder, sloughed and pliable, and then post-operative continuous bile leak through the DT for 20 days. And the patient was referred here. And we did an ERCP. ERCP was showing a a Klatskin tumor here. And then this is how the MRCP looks. And now I'm doing an ERCP here. I'm putting the guide wire into the proximal biliary tree. And as towards the end of the spectrum, now you can see this is how on a CBD you look. The Klatskin tumor will look. For people who have not seen the inside of the CBD, this is how a Klatskin tumor will look on a CBD. I'm using a biopsy forceps here. That's called a spy bite biopsy forceps. I take multiple biopsies. Under vision, you can take multiple biopsies. And under vision, you can pass the guide wire into intrahepatic biliary tree and put in a nice metal stent or a plastic stent. This is how I've gone into the proximal hepatic tree. So this is how it has been very useful to do an vision under vision. And this is another case scenario. A 57-year-old male post-lab coli presented with obstructive jaundice. Patient had on and off jaundice, and MRCP showed a small stone which was moving around. A distal CBD stricture was there. ERCP was attempted at a different center, and you can see the stone on the right side, a small stone, which got manipulated into the right hepatic duct, and I had to chase the stone and then use a laser lithography. Here, what we do is a holmium laser, which we are doing here, and you can see one shot of holmium laser. You completely pulverize the stone. That is, dusting of the stone can be done. And this stone is found in the right hepatic duct. And one shot, completely the stone gets pulverized. It was not a huge stone, but a stone of the size of around 8 to 9 millimeter in size. And you can see completely the stone is getting pulverized there. And another case in a 70-year-old male, known hypertensive. The patient was from Middle East. He was on clopidogrel aspirin. He had undergone a open cholecystectomy 20 years before. Patient had obstructive jaundice. What they did in the Middle East was they did an ERCP and stenting alone. They have not done anything else. The patient was referred, flew down from Middle East to our center here. From the airport, he came to our center. Here, what we did was, you can see here, multiple stones. I had to do 3 sittings. In fact, I calculated number of stones here. It was more than 60 stones I had done there. You can see the entire biliary tree was full of stones here. You can see. And spyglass was done, documented so many stones. And what is the advantage of using a spyglass is you have multiple stones. Complete clearance of the stones can be documented when you do a spyglass in this case. That is a major advantage of using a spyglass when you're doing this. And this is another spyglass where multiple stones were there. Another laser lithography is being done here. You can see there. I'm pulverizing the stone here, and I'm breaking the stone into few parts. Then I'm using a basket because a huge stone of 1.7 millimeter in size, 7 centimeter in size. So pulverize this, the green holmium laser there. Pulverize the stone into 2-3 portions, and then using a basket, I removed all the stones here. And this, as I said, 28-year-old pregnant female, 10 weeks gestation, referred for cholangitis, altered LFT. And what I did is I didn't use a C-arm here. No imaging modality was done here on table, and it is a huge stone here. What I did was I pulverized the stone using a holmium laser, then broke the stone into 2 portions. You can see there, I'm breaking the stone into portions. One stone is there, you can the proximal part, the distal portion, there's another stone. I'm using a spy forceps, spy basket it is. It's a spy basket. I'm retrieving the stone using a spy basket. After complete clearance, and again did a spy scope there, complete clearance. Here, endoscopic ultrasound comes to play a major role. I did an endoscopic ultrasound, complete clearance was proven by an endoscopic ultrasound. Then the patient stenting was done, the patient was discharged. This is a spy basket as I showed in the previous case. And electrohydraulic lithotripsy is there. This is another case where I'm showing here, where electrohydraulic lithotripsy is being done. You can see here, huge stones. You can use either an EHL or you can do on laser. Compared to laser, ESL is more safe because a laser, there are chances of you can piercing the CBD also. And this is very interesting case where they migrated the CBD stent in the proximal right hepatic tree. The on-table ERCP and cholangioscopy was done, where I was helping the surgeon who was doing a laparoscopic CBD exploration. I put in the scope and I chased the scope into the proximal part and the right hepatic duct, and then brought the stent into the portion where he had opened the CBD, and the stent was removed there. And these are the few indications. This already shown this spy bite, which I already shown here. Relative contraindications for the cholangioscope are acute pancreatitis, uncorrected coagulopathy, and altered GI anatomy, and any condition which precludes where you cannot do an endoscopy at all. And pancreatoscopy, a last few slides. pancreatoscopy is very rarely being done. We have done few cases, and these are the few techniques. This is a case scenario, 22-year-old male, where laparotomy is done for gastric perforation closure. They closed the perforation, but they missed the perforation, it was a knife injury, which had got injured the main pancreatic duct. The patient had a collection in the lesser sac. What we did was we did an ERCP there, and pus was flowing out of the pancreatic duct. What we did is we tried to do a pancreatoscopy. We couldn't do a pancreatoscopy. So what I did was I put in a ERC cannulation into the pancreatic duct. Then I put the guide wire into the entire pancreatic duct, and then I put in a long stent there. Here I'm doing a long stent into the pancreatic duct. Once the stent was placed into the pancreatic duct, leak stopped, and the collection was dealt with by doing a laparoscopic drainage of the lesser sac. The patient went home fine. The pancreatic duct cannulation stent was removed after 3 months. The patient is fine. And this is another case, interesting case of a pancreatoscopy, where I'll show next case is. You see here, I'm doing a pancreatic cannulation there, and a nice big stone was there in the distal CBD producing acute pancreatitis. This is one of the indications where you can do an ERCP, acute obstruction and producing pancreatitis. Remove the stone in the pancreatic duct. And see, I'm removing the stone in the pancreatic duct using a regular Dormia basket there. And you can see there is a huge stone. That's a pancreatic stone, how it looks like. And this is one of the centers in Professor Hara, where I learned pancreatoscopy. And this is another interesting case of pancreatoscopy here. And in the last few seconds, this is how a pancreatic duct stone, where we are using again the holmium laser, and the laser, you have to break the stone into the pancreatic duct. Very rarely you get like this. Once the pancreatic duct stone is broken, I'm using a basket here. You can see the distal part of the pancreas. I'm using a basket, and completely the stone clearance is done, and then the pancreatoscopy is done to ensure that the pancreatic stone has been completely cleared. And then you put in a stent, place the stent for a period of 3 months. These are the few types of the pancreatic stents which we use. They are of the 3 French size or 5 French. We don't go anything more than 5 French. Usually the length is around 5 centimeters. And with this, I'm coming to the end of the therapeutic endoscopy. There are still more lots of things which can be dealt. For lack of time, thank you. Thank you again, Dr. Sunil and Dr. Arunima, for allowing me to be a part of this deliberation. Thank you.
Thank you very much, sir. And I would like to ask you a question. The role of prophylactic pancreatic stenting in ERCP, sir, if you could answer that.
Yes. See, there have been, I think people here, stalwarts are there. There have been many instances when I used to want to cannulate the CBD, I'll be cannulating the pancreatic duct. When I want to cannulate the pancreatic duct, I'll be cannulating the CBD. So this is the only instance where I would say a cannulation of the pancreatic duct can be done. But that also, if you are not an experienced person, I would say don't do a cannulation of the pancreatic duct, because there have been n number of instances when you try to attempt to cannulate a pancreatic duct, pancreatitis happen, and pancreatitis can become lethal, and potentially it can, 20% of the cases can become lethal. So if you're not experienced, don't attempt to do that. Thank you.
Yes, Sadhvi, please take over.
Thank you very much, sir. It's indeed a pleasure to hear such enriching knowledge on endoscopy and provoking young surgeons to learn endoscopy, colonoscopy, and even ERCP. I would also like to learn ERCP. I am still amateur in endoscopy, sir. So I would really love to join you for learning ERCP.
Anytime, Satya.
Don't worry. I can see passion and fire in your belly. You will do it.
Thank you, sir. So we move to our last session by Dr. Arunima ma'am, and she will be talking about my favorite topic, which is training in endoscopy. And our respected chairpersons are Dr. Sunil Kumar sir and Dr. Satish Mehta sir.
Yeah, thank you. What to say about Arunima? For the last more than a decade, she has been with me, and now she is heading a department of surgery in one of the major Tata Motor Hospital in Jamshedpur. Other than being a proficient GI surgeon, breast surgeon, laparoscopic surgeon, and of course the endoscopic surgeon, She has been streamlining and being the chairperson. So I will request Satish Midha to say a few words because to Arunima, so that I don't get bashed talking about her.
Thank you, Dr. Sunil. We have seen Dr. Arunima grow. She has done wonderful job academic chapter of AS, and academically she has many of the events successfully, and you have been her mentor, and we have been seeing her grow over the years. Over to Arunima for her presentations.
Thank you so much, sir, for those kind words. And is my screen visible?
Yes, ma'am.
Yeah. So as Satveer said that this is his favorite topic, I think this is the question that has been asked all across Jharkhand, that how do we get trained in endoscopy? And training in endoscopy is not only about how do we get trained in endoscopy. I think it's a philosophy, and I would start off with editorial that Dr. Sunil and myself, we had written long back in 2012 in New Indian Journal of Surgery, where we talk about this vision of endoscopy for surgeons. And it was that time when gastroenterologists were completely taking over all the endoscopic facilities from surgeons. And we strongly believe that this is not something that we should give away on a platter, as our one of the faculty also mentioned, that we have, Dr. Abhay Dalvi said that we have offered the gastroenterologists this endoscopy on a platter. So I think this was the vision with which we had started, and Dr. Sunil and myself, we have been very passionate about promoting this endoscopy for surgeons. And today it's really a very big day for us when we have made this humble start. So who is an endoscopist? The term endoscopist should be used for all physicians, whether they are from the medical fraternity or they are from, the surgical fraternity. Anybody who is dealing with endoscopy is an endoscopist. And the need of the hour is designing endoscopy unit where the surgeons and gastroenterologists should work in a symbiotic and synergistic environment, and that should not be completely taken over by gastroenterologists. Endoscopy training and skills need standardization. That is what is more important. And we need to have accreditation of these practices. And instead of discussing who should be trained, why not surgeons, why gastroenterologists, we should be trying to have a standardized procedure, and whoever shows passion, interest, and dedication to it should be one who should be trained for endoscopy. Looking at surgeons in endoscopy, the diagnostic role is very well established. For endoscopy, especially in GI, we know how well it is established, and we all depend on endoscopists for this purpose. And therapeutic endoscopy, as if we look at therapeutic endoscopy, it should always be considered as a surgical procedure. All the principles that you use for surgical procedure, like checklist, the complications, everything that you get a consent form, a proper consent form, everything should be done when you take up a patient for therapeutic endoscopy. And in the present era, we all know that there is an enthusiasm for combining this skill and talent and experience of surgeon and gastrointestinal endoscopist, because we are moving towards what is called scarless surgery. So now if we have to move towards these advanced procedures of scarless surgeries like notes, poem, all that we saw in throughout the presentations today, how would we do when we don't know endoscopy? We would be stuck. There are multiple laparoendoscopic procedures which are becoming standard of care now. So again, you have to know endoscopy to move to these levels. Like if you come across pancreatic complications, like if you've got a pancreatic pseudocyst, laparoendoscopic procedure is there. Even by endoscopy, you put a stent, and that is what has to be done. And it's, I think, a very good thing for patients. So we as surgeons, we need to know that endoscopy is a very big armamentarium in our hand, which we should learn. And there definitely is an undisputed role of surgeons when the complications are. The gastroenterologist, if there is a complication like a perforation, they don't manage it. It's the surgeon who manages it. So also knowing what endoscopy does as a complication is very important. You would know how to deal with it as well. As far as endoscopic training for surgeons are concerned, it is not uniform across the world. In Canada, endoscopic training is a part of core curriculum in general surgery residency. Even American Board of Surgery has recognized that endoscopy education is fundamental component of general surgery residency. European countries, there is no consensus, but yes, they are definitely moving towards it. Coming to, these are the various articles that you can see that they were designing these principles for training in endoscopy. This is from American Society for Gastrointestinal Endoscopy, and they do talk about both gastroenterology fellowship and surgical residency, who should be trained for it. Even European Society of Gastrointestinal Endoscopy, they also talk about both gastroenterology and surgical fellowship training in endoscopy. As far as endoscopy training in India is concerned, there is no licensing for practice of endoscopy in India as of date. And there is no medical university in the country which has an organized training program for junior doctors who are aspiring to learn endoscopy. We do not have a uniform curriculum, certification, or credentialing for endoscopy. Though there are multiple centers, like, we have got stalwarts in our program itself, like Dr. Subhash Khanna or Dr. Govind Raj, we have got so many of them who have centers. Zen Hospital, Dr. Roy Patankar, they all have centers where they do have these short-term training courses. But if we talk about having a uniform curriculum or certification, it definitely is not there in India, though IAGS is trying to develop this curriculum as well. So if I talk about training in endoscopy, I would divide it into 4 levels: pre-training, in-training, performance assessment, and credentialing. Now, pre-training is knowledge-based training. And then it is followed by simulation training. You need to know, because all of us know that the eye doesn't see what the mind doesn't know. So all of us have to increase our knowledge as far as endoscopy is concerned, and then only start endoscopy. It's not only about picking our endoscope, and just like you say that for a surgeon, it's not only about cutting. You need to know the indications, the contraindications, when not to cut. So it's the same thing for endoscopy. You need to have a knowledge base which you have to increase. In training, it has to be hands-on courses, and that will continue when you are practicing it. So it's a clinical training ongoing. Performance assessment is a very important part of training in endoscopy, because you need to have a structured performance assessment to know your level of competence. And there are various competency tools that are available, and they are being used by the American Society, the European Society, and there are many others, and these can be custom made for whatever institute is providing it, or if we have a uniform curriculum. Credentialing it also is very important for safety of patients and safety in our practice. So credentialing of endoscopists should be done, and that should again be through a committee, and there should be ongoing practice monitoring as well, because with the daily advancements in techniques, there is a need for ongoing upgradation of your skills. And what we are doing here today, what we are trying to sensitize the crowd is to knowledge-based training. This is just a prelude, because we are just trying to give you a short helicopter view of what endoscopy would be. So you have to increase your knowledge, and this is the first step towards it. Ideally, a course content for e-learning would include the role of endoscopy. You also need to know how important a consent for GI endoscopy is. Then the normal upper GI examination, patient-centered care, risk assessment for GI endoscopy, complications, safe sedation, and safe diathermy for GI endoscopy. Knowing the video endoscope and endoscopic images, only then will you be able to interpret them and use it in your practice. The enhanced detection of GI pathologies, like the various things we were talking about, we have got magnification endoscopy, we have got narrowband imaging and all that. So all that needs to be known. So this is increasing your knowledge base. And then examination of lower GI tract would be a separate course altogether. So these are what has to be the content of e-learning. This is just an example what I picked up from the European Society of Gastroendoscopic Surgeons, and they have been developing curriculum. Now, development of curriculum itself is a very specialized procedure. So developing curriculum is you have to have committees who study what is the need, and then they have they have a chairperson, they have members in that curriculum development, and based on evidence-based literature and the skills that should be the cognitive and technical skill that the person should acquire, based on all this, the curriculum is developed. This is an example of the curriculum for advanced endoscopy, where they talk about the sections where there is pre-adoption training and autonomous implementation and assessment of proficiency. So pre-adoption would define the skills and competence that are necessary prior to engaging in advanced techniques. So when we talk about basic endoscopy, again, it would be the skill and the knowledge that is very important for all of you who are aspiring to learn endoscopy. You have to acquire that and then come to the training where you have to have steps to acquire the competence. And the different aspects of learning that procedure need to be known to you. And once you have been trained for that, then you have to have the assessment of your proficiency, whether you are technically independent for doing it or not. So going through literature, this is not something which is, this is not from a RCT, but various RCTs combined together. The American Society of Gastrointestinal Endoscopy has recommended that before you can be assessed for technical evaluation of performance standards, for flexible and sigmoidoscopy, it should be 25 to 30 cases minimum. UGI 130. So Satvir is reaching near that. Colonoscopy 200, ERCP 180 to 200, and EOS 100. Now these are not absolute figures because different trainees would have different levels of competence and would achieve the level of competence with different numbers. So what is more important is the percentage of doing the technique in a particular way. Like for performance standards, if we look at expert endoscopist, like we talk about expert endoscopists like Dr. Govindraj, for him it is expected to perform at 95% to 100% of technical success level. But when we talk about trainees, then establishing a standard of 80 to 90% of technical success, then you are deemed competent in a specific skill. Now, when I talk about 80 to 90% technical success, it is like if you're talking about colonoscopy, then your cecal intubation rate needs to be in the range of 80 to 90%. If you're talking about UGI endoscopy, then again, your reaching D2 should be 80 to 90%. So in a given program, there may be small variations in standard of expected proficiency, and they may be set as per as appropriate. As I said, you have to make it custom made for the region and for what is the level of work that you plan to do with that endoscopy. So, and again, varying procedures have varying complexity. And again, it will be according to that. And it is, but what is more important is that it will be uniform across all the trainings. Like if I'm expecting a 80 to 90% D2 intubation rate, it will be across all trainees. Only those who have attained that should be given this credentialing, because it might be that X has achieved this 80 to 90% in 100 cases, but somebody might achieve it at 200. But you will have to wait because the performance level is going to be uniform. So there are various assessment tools, as I mentioned, and these are all available on net. Like you've got gastrointestinal endoscopy competency assessment tool. This is for colonoscopy, again, colonoscopy skill assessment tool. But American Society of Gastrointestinal Endoscopy has devised this assessment of competence in endoscopy. And this is the form for upper GI, and this is the form for colonoscopy. So there are various parameters on which you are assessed. And now again, assessment would be defined by the institute providing you this, or the curriculum, they're providing you this training. So it can be every case. It would be that after every 10 to 20 cases, you would be assessed for the next 5, or however, but this needs to be incorporated in the training module for assessment. Now, there's a special word called surgical endoscopy, which I think we should start using, because surgical endoscopy would be a more appropriate term for defining the entirety of therapeutic endoscopic procedures, because we have seen right now how it is there in bariatric surgery, how it is there in ERCP. All these therapeutic procedures, they can be a part of surgical endoscopy. There are procedures which need all the surgeons to enhance the endoscopic skills, like the notes, endoscopic based treatment of gastroesophageal reflux disease, the GI bleeds, and as I mentioned about the pancreatitis complications. So there are many more to the armamentarium. This is just, I have given you as examples. So all of this would need endoscopic skills. So I would like to give a takeaway message that endoscopy should be a part of surgical residency training curriculum. Duration and number of diagnostic and therapeutic procedures should be defined and stated in surgical residency core training. Standards should be followed during postgraduate endoscopic practice, and that should also be defined. And endoscopy centers and endoscopists should be accredited. Theoretical and practical training programs should be held at centers at particular interval even after graduation. And retraining and skill upgradation programs should be structured and available, which includes endoscopists like us as well, who want to move ahead in further endoscopic procedures. And I would like to end with this, that the future of endoscopy relies on the current practice of eligible doctors who have the knowledge and skills in endoscopy rather than who perform endoscopies. So as surgeons, if we want to move ahead in our practice, I think endoscopy will form a very important thing. And if the enthusiasm of surgeons across Jharkhand remains, I think Sunil sir and me, we are very committed in taking these programs ahead. Thank you very much for your patient hearing.
Thanks, Dr. Arunima, for a lovely presentation. I know the things have changed. I think Professor B. Krishna Rao is here with us since morning. He has been continuously watching us. When I think he has different experiences. When we wanted to learn endoscopy, we had to run from here and there. I remember going to Dr. B. Krishna Rao early 90s. And then moving to all other gastroenterologists and picking up here and there. Now we have simulators and other things. So, but as you have rightly said that we have to stress as an ASI and other organizations also that it should be a part of the residency program, so that at least basics of endoscopy all surgeons should know. And as things are moving, we are having more and more procedures being done by endoscopy besides the RCP, POEM and other, even the resections of early carcinomas, EMR, all these things are being done. So we may have one small comment from Dr. B. Krishna Rao on the training aspects, means what he feels.
Thank you, Satish. I've been following all the presentations and the training that is required. When I was doing the training, I had to go from one country to another country, States, UK, Japan, Germany, to pick up what was being done. Today, you can sit at home and watch the programs that are going on in endoscopy. You can watch the procedures live, recorded, get your doubts clarified. But it does not mean it makes you a good therapeutic endoscopist. You have to have a training supervised by a senior who has done enough number of therapeutic procedures, who can pick up whether there are any faults in your methodology. So the entire process of learning endoscopy and executing it has become very precise, concise, and is localized. You don't even have to go from one city to another city. Today, almost all major cities have institutions that are doing excellent therapeutic workshops and work. Of course, there are highly specialized ones for which one has the inclination and time. They have to go there for training and implementing it in their own places. But for basic diagnostic and basic therapeutic endoscopic work, one can easily learn it in their own cities. Thank you, Satish.
Thank you, sir. Thank you very much. Two comments, one on training aspects. I firmly believe, for a trained surgeon, if one monkey can do it, other monkey can do it. See, if I am doing something, why can't my trainees do it? It's just a question of transferring my skill to him. Because anything, any knowledge or training which we have acquired is a God's gift who someone else has given to us, and that needs to be transferred to the younger generation. So that's my firm belief. That's number one. Number two, on the talk of Arunima, what can I say? Arunima, you have made me proud. That's all. Thank you very much. So now at the end of it, because it's lunch time, let's have a little short, because there's a kind of valedictory. I can see Professor Rao is there, Satish is there, Achal is there. Arunima, can you handle this valedictory? And and Suraj Singh Chauhan, thank you, Suraj, for being here. A very dynamic surgeon who has come to Jamshedpur. So Arunima, handle this valedictory so that people can have lunch leisurely.
Yes, sir. I would like to thank each faculty and each participant, each chairperson for sparing time on a Sunday. Though we have a complete lockdown in Jharkhand, but in other states, it is not a complete lockdown. So thank you very much for being a part of this. And it's a humble start towards a long back dream that Sunil sir and me had. And this kind of support from all across the nation, from all stalwarts, I think I can only say thank you. And before we end, I would like a few words from the ones we have. We have got Achal sir here. So Dr. Achal Gupta, if you want to say a few words, and then we can have a few closing remarks from Dr. B. Krishna Rao, and then we would end. Dr. Achal?
Yeah, we can
thank
also
you,
ask Suraj Chauhan to speak.
Yes, yes, we will. Yeah.
It's very heartening to attend these programs. Actually, I was doing endoscopies about 5 years back, but because of paucity of time, I left it actually. I was doing some other laparoscopic work and open work and all those things. But I made sure that my department got all type of scopes. And I'm very proud to say in Department of Surgery, Medical College Gwalior, at least 5 surgeons are doing a lot of endoscopic work. So that is one thing. And other thing is that these lectures were quite tremendous, very elaborative and very lucid lectures were there. And I also firmly believe that surgeons should know endoscopy. They should know endoscopy. And I thank you all, especially Sunil, for inviting me to attend this program. And I was there all the time. In between, I just went for a hospital to see a couple of patients. That's all. So thank you very much. Thank you. Thank you, Jharkhand State.
Nice seeing you, Achal, after a long time.
Dr. Chauhan?
Thank you, sir.
Yeah, indeed, a very nice conference, and compliments and congratulations to the organizing team on their efforts in popularizing endoscopy among surgeons, particularly in Jharkhand state. It is due to the stature Dr. Sunil has that he's been able to get such luminaries to attend and share their expertise with all the participants and make us all wiser. Once again, thank you for conducting such an excellent conference and spreading awareness that endoscopy is the way forward and all surgeons should be exposed to this. Thank you very much.
Anybody else wants to make any statement before we invite Dr. Rao? Dr. Sushil, Dr. Om Prakash, Dr. Midha?
So I must compliment Dr. Sunil, Dr. Arunima, and all the organizing committee members who have worked hard. And as you all, I also have passion for endoscopy. It's to my heart because being a surgeon, and I am proud that I could start many of the therapeutic procedures here in this part of the country. So I even wish to go even further ahead if possible. And learning is a continuous process. We have to keep on learning. In this era, in this COVID era, somehow or the other, when even the lockdown was there, I was doing more of endoscopic work, and they were real emergencies. I had, I think, more patients of obstructive jaundice, cholangitis, who could not otherwise wait. So I had to do them. So I think that this was available in this part of the country. Otherwise, I remember in early 90s when we started, for even small complications of lap chole, we had to send the patients to Mumbai, Kolkata, and Hyderabad. And sometimes I remember the days when I had to accompany few patients to these cities. So Now, many people are doing these procedures and many are willing to learn. And this platform will also act as a catalyst. And we will go further ahead and organize few therapeutic hands-on training and maybe invite these faculties when the things are normal. Thank you very much. And congratulations.
Thank you, sir. And I would like to place this on record that this is the first of the series that we are planning for endoscopic programs, and all the effort has been by Dr. Sunil Kumar. He is the one who has been working very hard on this. We have just chipped in, but he is the one who has conceptualized it, worked hard to get all faculty and organize this whole thing. Thank you very much, sir. I would want you to invite Dr. Rao.
And I have you and everybody else, like Satvir is there. I can see Sushil Pandey from Daltonganj who does diagnostic endoscopy. Sushil will take you to therapeutic endoscopy, don't worry. And Satvir has been a wonderful addition to the armamentarium of Jharkhand surgeon, young Punjabi boy, but with a lot of enthusiasm, Satvir. Before I invite Satvir and Dr. Professor Rao, and before I place on record our deep gratitude to Keystone, led by Anand, Sachin, and his team to always making our audio, visual, and virtual conference very free. Satvir, you are there?
Yes, sir.
Just one line. You are the future of Jharkhand in endoscopy.
After coming to Jharkhand, I came back to Jharkhand from Mumbai, and the first interaction I had with Arunima ma'am and Sunil sir was a breast conference. And after that, since October, they have been my mentors, and they have always holding my hands in every conference, and I hope I help them in any way, every way around. And I hope I share similar interests what they seek for young surgeons. I hope to help them and even learn a lot of things from Sunil sir, Anurima ma'am, RP Srivastav sir, Satish Mudda sir.
Thanks, Satvir. I can see going in greater height. Sir, to just conclude from Professor B.K. Rao, sir, mentor and mentor of all the endoscopic surgeons and all of us, sir.
Father of endoscopy.
Father of endoscopy, definitely. That's why he called him.
Arunima and Sunil, this is a very good beginning. They have done the mostly a theoretical part. And I'm sure the COVID will go off at least by year end, I hope so. And you should plan to have hands-on training after that. And before getting on to patients, we can have stimulators who get the candidates to familiarize themselves with the handling of the equipment and the interiors as shown in them. So I look forward to further courses, conferences organized by the Jharkhand team in the future. Well done. Thank you.
Thank you, sir. Once the COVID is free, that physical endoscopic training will be in Jamshedpur, sir, led by Arunima. Thank you. Back to Arunima to conclude.
Yes, sir. Thank you very much. I think we are quite late and we have been holding all these seniors from lunch. B.K. Rao, sir, heartfelt thanks to you for being throughout the session. It was really very encouraging to have you because I have been hearing so much about you as the father of endoscopy for all surgeons. And I would like to thank Dr. Achal Gupta also for being with us throughout, Dr. Chauhan, Dr. Mitha, and all other participants who are there on YouTube as well. Thank you all. And Satvir, thank you very much. It's a team. So thank you very much once again. Anand and team, thank you again. Anand, you can come on the camera this time and just say thank you so that we wind up the session. Anand is a very important part of our team because most of our programs have been going through him. And he has been giving us seamless the talks and everything. So Anand, you can just come and say and then we say audio to all. Yes, Anand.
Thank you, sir. Thank you for giving this opportunity to serve you all. I'm so happy that working with you all. So I'm also learning every time new things. Thank you so much for everything.
Anand is based in Bangalore and does a wonderful kind of job. His team is excellent, Keystone.
And
okay.
he is with us on all the conferences from morning till whenever we are doing. And I think he's half a doctor himself now.
Thank you. Definitely.
One fine day.
Thank you so much, everybody.
Thank you.
I think
Thank
we're
you.
good. Thank you for everything. Be safe.
Let's get back.
Be safe.
Yes, sir. Yeah. Let's see. All of you enjoy Sunday afternoon lunch.
Looking forward to the French Open at 6:30.
I know. And the Euro Football Championship is also going.
That is comes at late in the night.
I know, 6:30 and 9:30.
There was the football became more exciting because a player had a cardiac arrest on ground and was given CPR. On ground, he was revived.
Yesterday?
Yes.
Yeah, last night.
Yeah. And the captain of the team gave him CPR. That's interesting how the training of CPR all across helps. And
He's
it's
alive. He's alive.
Yes, he is.
Right. Good.
Okay.
Yeah. Yesterday was between Denmark and Finland.
So Denmark, the player was from Denmark, and the Denmark captain gave him CPR before the medics arrived.
Okay, it has been interesting
Bye.
morning and afternoon.
Nice.
Enjoy your lunch and be safe.
Thank you, sir.
Okay, sir. Okay, Sivraj. Okay.
Thank you, sir. Thank you very much, sir. Thank you and good day to you, sir.
Okay, take care.
Thank you, Anand. You can put off
Thanks.
this off from YouTube. Thank you.